central hypersensitivity. Like the routine IBS where they have visceral hypersensitivity, these people also have central hypersensitivity. So many other issues are also there. That's why surgery scores over endotherapy where they do head coring also, where the pacemaker for pain is there. So such patients are very great. And even total pancreatectomy is done for selected cases, such and non-responders.
This pancreatic symptom alone cannot help from anything. I mean, after clearing also the patient understands pain.
So most of the time when the ductal clearance is done with the CSW, it is always followed by an ERCP. So routinely pancreatic sphincterotomy with stenting is done. All the groups are doing a routine ERCP, though there are data to suggest ESW alone versus ESW plus ERCP. So routinely sphincterotomy is done. So I don't think sphincterotomy alone is going to help because there will be upstream strictures. So we have to clear the duct. Unless we have the stone sitting in the ampulla, where we have removed the stone and done a sphincterotomy. Otherwise, clearance is needed. Within 24 hours, within 24 to 48 hours.
Is there a reason for that?
The state space, whether I pronounce it right, I don't know. The fragment, less than 3 mm fragments are confirmed during ESW procedure. These fragments can clump and go and block the ampulla. It's called state stress, and the pronunciation is correct. So in order to avoid that, within 24 hours, we have to do an ERC.
What about the chance of developing pancreatitis?
Post ESW pancreatitis can happen in 3 to 5 years. All routine PEP measures are preventive measures are taken. 3 to 5% risk of post ESW pancreatitis.
Give indomethacin alone or isosorbate dilated also?
There is a talk on PEP with Dr. Rajesh. He has given a password for avoiding PEP.
I enjoyed your talk more, very complete exhibition of skills. And only thing is I want to ask is laser lithotripsy for a pancreatic stone will be quite difficult. It is not because the stones are hard, it is because the stones are white. They reflect all the laser light, so there will be always difficulty. And we have done few cases, we have selected cases where the stones are only in the head. Very close to the ampulla, we have done laser lithotripsy. Otherwise, putting a spyglass deeper into the pancreatic duct is very hard.
The multicenter trial that they showed in that inclusion criteria was less than 3 stones confined to head. Less than 3 stones confined to head.
The Boston has to come, or somebody else has to come with a more softer, less rigid colonoscope or pancreatic scope, as you call it. Then we'll be able to, smaller one, we'll be able to go to the display.
In all these studies, they have used EHL more than laser, sir. EHL is commonly used in laser. There is something called a new laser. What we use is holmium. It's a tulinium or something. That is more effective for pancreatic.
Light is there, they reflect, the white stones reflect the light, so they are not quite effective for pancreatic stone, white, because of the white color.
These studies, 90% EHL they use, sir. I showed a list of contraindications for ESW. Whenever you have multiple upstream strictures, dense stone burden, extensive parenchymal calcification, tail predominant disease, or large cirrhosis, head mass, such things you should directly go for. There is a CT criteria for choosing for ESW. If the Hounsfield index is more than 800, you should not choose for ESW. You have to directly go for search.
I think we'll conclude.
Thank you, sir.
Thank you.
Thank you for the session. Let's move on to the next session.
Okay, so moving on to the next session, so it's like we are honored to have with us Dr. Santa Narayanan sir from Chennai. So he will be presenting on this topic, GERD, what is known, what is new. So we'd like to invite the chairpersons for this session, Dr. Padmanabhan sir, Dr. Shivasubramanian sir, Dr. Ubadha sir, Dr. Ramaniya sir, Dr. Radhaman and Dr. Vic Sarman.
Talking before the experience of August 30th, I not only developed but also supragastic principles. It's not that easy. I can see the refractory CERD better. 10 minutes was therapy.
So we have to clear the duct. Unless we have the stone sitting in the
is superior to a quadruple regime. There are two meta-analyses, one is superior, one shows it is superior, one is non-inferior. And in previous cases also, there is a 90% chance of, even if the failure rate you have given is superior to a quadruple regime. There are two meta-analyses, one is with 1% you have a 85% chance of recovery. So for whom I should not give, those who renal and hepatic function, pregnancy, lactation and pediatric patients, and contraindicated in hypersensitivity and those who are on protease inhibitors. So major adverse effects are same like proton pump inhibitors only. So a meta-analysis showed no significant difference. So what is the dosing? So the last thing which we want as a gastroenterologist, in erosive reflux or esophagitis, 20 milligram once a day for 4 weeks. See, there was a study with 4 weeks of vonoprazan versus 8 weeks of PPA, and vonoprazan was superior to PPA 8 weeks. But you can, even if you want, you can extend it up to 8 weeks. In gastric and duodenal ulcers, I have skipped the whole slide because it was shown it was non-inferior to lansoprazole. And for maintenance, you can give 10 milligram of vonoprazan. And in H. pylori treatment, you can have dual, triple or quadruple. Dual is amoxicillin 1 gram twice a day or 750 milligram 3 times a day. So in India, clarithromycin resistance is high. So instead of giving many antibiotics, just amoxicillin and vonoprazan is superior to your standard triple drug regime. The others is the triple and quadruple is just substituting PPI. So in summary, PCABs are rapid, potently active anti-secretory agents. They are superior to PPI and GERD and H. pylori management. Third is they are non-inferior to PPI in treating gastric and duodenal ulcers, and do not prescribe the patients who are on clopidogrel and vasogrel, and do not prescribe in patients who are pregnant, who are lactating, and in children. Thank you.
Thank you, sir, for the wonderful session.
And for Dr. VS's question, post ESD ulceration with PCABs is superior to PPA. It is a meta-analysis.
I never asked any question.
Thank you. You will take it more.
It is my pleasure to welcome Dr. Gokul Vijay, consultant gastroenterologist, Medline Hospital, Chennai, who will be sharing his insights on the newer modalities in GERD. Goodbye to belching. Please join me in welcoming Dr. Gokul sir to the stage.
Respected teachers, dear chairpersons, colleagues and friends, good afternoon to you all. I bring warm greetings to Medicare Hospitals. Before going to the talk, let me thank Professor Kandasamy sir, Dr. Shafi, Dr. Paulishresh ma'am and the organizing team of Midterm ISG for this opportunity and for the wonderful conference. So enough have been discussed about the role of PPA and PCAPs in the treatment of GERD predominantly. So my scheme of my talk would be to discuss about the endoscopic treatment options available and the limitations of it. So in a patient who is treated with PPI, the patient responds to it is called PPA responder, and those who do not respond is called PPA non-responder or refractory, PPA refractory GERD. The options in the presently is the gold standard treatment, which is surgical fundoplication. So let me tell you about a few things about the surgery before going to the endoscopy aspect of it. The indications are predominantly PPA responsive GERD. Patient who is desiring to discontinue PPA because of the perceived side effects or the compliance issues, who has got a Barrett's, large hiatus and obese. So these are the typical indications for anti-reflux surgery. A pre-op evaluation is a must with upper GI endoscopy, barium and initially you know that the laparoscopic fundoplication is being carried out, the gold standard being Nissen's fundoplication 360 degrees. Here a gastric fundus is wrapped around the lower esophagus. Along with that there is a reconstruction of diaphragmatic hiatus that happens. In a patient who has got a esophageal hypomotility, then a partial fundoplication is being carried out. Not without issues. Anti-reflux surgery can cause dysphagia, which is a very common side effect. Early dysphagia resolves in 2 to 3 months, whereas 10% can have persistent dysphagia because of the diet trap. Gas bloat syndrome happens in more than half of patients at the end of 6 months. Bloating, inability to belch or vomit, postprandial fullness can happen because of impaired relaxation of fundus. Diarrhea can happen in significant amount of patients because of hurried emptying, SIBO and pre-existing IBS. Long term, most of them they go back to PPI. At the end of 5 years, 57%, end of 15 years, 82%. Anatomical failures of fundoplication can also happen because of technical issues like herniated fundoplication, slip Nissen's, paraesophageal hernia, and malposition gap. Now, to overcome the side effects of PPI as well as to avoid invasive procedure which has got significant adverse events, there was unmet need to develop anti-reflux therapy endoscopically, which could be effective, minimally invasive, and acceptable. So, patient selection is very important for endoscopic anti-reflux therapy. Patients who are PPA responsive, they do well, and endoscopic to rule out contraindication, especially large hiatus, severe esophagitis, Barrett's or peptic stricture should not be chosen. Gastric emptying study to rule out gastroparesis, manometry to rule out motility disorders, and to confirm GERD by 24-hour period study. Now, these are the parameters that are assessed after endoscopic anti-reflux therapy. Clinical data in the form of GERD health-related quality of life questionnaire, the frequency scale of symptoms of GERD, and PPA discontinuation rate, Hills gave reduction at endoscopy and PH study showing reduction in D-Newton AET of the parameters which are routinely assessed. Now conveniently divided into radiofrequency therapy, which is predominantly STETA, transoral fundoplication by means of Vertex or Esophax, and mucosal resection or ablation techniques. STETA is the first endoscopic treatment approved by FDA where radiofrequency energy is delivered to muscle layer of the lower esophagus using specially designed catheter which has got a balloon and 4 needles popping from 4 sides which delivers energy. The mechanism is that it causes hypertrophy of ileus muscle, reduces transient ileus relaxations and causes reduction in the esophageal acid sensitivity. What is the evidence? We have this meta-analysis in 2012 which of 1,400 odd patients. Significant reduction in the heartburn score and the health-related quality of life score, reduction in D-Newton score as well. Another meta-analysis 2017 with 28 studies, more than 2,400 patients. Only 50% of them are taking PPI and significant reduction in esophagitis and acid exposure time. Coming to endoscopic fundoplication, it tends to create an anti-reflux valve by fixing the fundus around the lower esophagus. We have this Vertex device, which is a special device where tissue is grabbed between 2 applicator arms and preloaded suture is delivered. What is the evidence? We have 13 studies involving more than 420 patients. 66% experienced more than 50% improvement at the end of 6 months, and at the end of 12 months, 67 could discontinue PPI. There was non-significant reduction in acid exposure time. Average procedure time is 22 minutes, safe and effective treatment, and compelling alternative to surgery. Transoral incisionless fundoplication is a special device where omega-shaped valve is created at the lower esophagus, the length of 3 to 5 centimeters, and around 15 to 20 polypropylene fasteners are deployed. What is the evidence? We have from 32 studies, efficacy rate, success is 99%, significant improvement in the scores, hernia can also be reduced, small hiatus hernias. PPI could be discontinued in 89%, adverse events 2%, safe and effective. The advantage of mucosal ablation or resection techniques like ARMA or ARMS is that no dedicated device is required and it can be, a retreatment can also be offered. Anti-reflux mucosectomy was pioneered by Illinois in 2014, where the idea actually came from EMR of Barrett's, where the significant reduction of GERD happened. That is how the idea came into vogue. A butterfly-shaped resection is carried out, leaving a small amount of mucosa along the lesser greater curve. Either a cap-assisted EMR or band ligation-assisted EMR can be done. Coming to mucosal ablation, this is actually again introduced by Illinois in 2020 as a rescue treatment after arms. Here, scarring is created around the G junction either with a TTJ knife or with an APC probe. Now, comparing these two, we have a systematic review meta-analysis of more than 50 non-randomized studies. High technical success, high pooled short-term success at the end of 6 months, 1 and 3 years is more than 70%. Patient could be off PPI at the end of 1 year was 64%. The adverse events being dysphagia, which required balloon dilatation in 7%, bleeding in 2%, and perforation all occurred in the arms, but not in the arm. Now, what are the limitations? Significant symptomatic improvement happens after ERT, but objective evidence, if you see, like LES pressure increase or reduction in acid exposure time, that is not there. So there is also a need for PPI could only be reduced but could not be completely eliminated. We don't have head-to-head comparison between one modality and another, and we don't have long-term data except for STETA and TIF. What does the guidelines have to say? The ISG guidelines 2022, STETA cannot be recommended because of inconsistent efficacy data. TIF could be considered in a patient who has got troublesome heartburn or regurgitation who don't wish to undergo surgery and who do not have severe esophagitis or a hiatus more than 2 cm, and those who have regurgitation as a predominant symptom. What does the ESG recommendation say? TIF may have a role in patients with GERD who don't want a PPI or a surgery, but not to use it widespread because we don't have a good efficacy data. The other two procedure news which I did not discuss wantedly, and arms they don't recommend because of inconsistent efficacy. Now, to conclude, GERD is increasing in prevalence. 40% they don't respond to PPI. The numbers could be less because after the introduction of vonoprazan. The indication for the gold standard surgery would be a large hiatus, obese patient, and large volume reflux. Endoscopic therapy as the effective minimum invasive therapy could be offered to patients who are PPI responsive, not willing to take PPI and don't want surgery. But they should have a minimal esophagitis, small hiatus, skills grade 1 and 2, and non-obese. Thank you very much.
Thank you, sir, for the wonderful question. Now the floor is open for discussion.
This is only a correction. Pediatrics goes up to 18 years. That's not 12 years, no longer. Then you get young adults. Then adolescents, young adults, adults. Postgraduates should know pediatrics goes up to 12 years. You say contraindication pediatrics. That's why the answer. Agree? The second thing, I do not know really how many people have suffered from PPA complications of chronic disease. Why we are not documented in Tamil Nadu? We have borrowed the information from somebody. What will be the fate of a pharma group if they have PPA, double dose PPA plus vonoprazan, two products of same medicine in two different names in the same company? What will be the fate? Ideally, this topic should be given, not instead of this. It should be a debatable topic. Why? We don't have any experience. Second thing, I would have appreciated if you would concentrate a little more on 1% rather than on things which have not yet come to the market. We should talk this type of audience only for practical, what I see in my office. Please avoid in future. I am not criticizing you. Please, you are the closest. That is why we should always discuss when there is an overlap topic, like overlapping medicine. I should always request people, what you talk in the auditorium is different from what you practice outside. Please, let us avoid this. It should be a debatable topic. Then, that will make interesting. Case-based decisions, panel decisions. That should have been taken. Clinical pathological is ideal for annual process. But now midterm conference, I am a practitioner, sir. I am not an academician. I am not at all an academician. I want to reach the mind of everybody. That's all.
So regarding the lifestyle modification in GRD, we are asking the patient to lie on the website. Yes, the reason for asking the patient to lie on the website is these, what is called the gastric contents, that is a puddle of gastric contents. They lie away from the gastroesophageal junction when you lie on the left side. That is why we are asking the patient to lie on the left side rather than the right side. Another one question for Shankar Narayanan. What is the room criteria for functional heartburn and how will you manage functional heartburn?
This is not the topic for the day. I am supposed to give only PER. I am not supposed to talk on functional anatomy. It's a differential diagnosis. Sir, please, let us, I will give you more information during coffee time.
Thank you, sir. Thank you very much. And if there are no other questions, we'll
I have a question for Dr. Rajesh. I saw you going on to do a ERCP after creating a perforation, after seeing. My opinion is if you see air, free peritoneal air during a procedure, the procedure should be stopped. So why I'm saying that is, I want juniors to take this in mind. In many places, we still use air. Rajesh went on to close the perforation because he used the carbon dioxide. So if anybody uses air and create a perforation, it should be stopped. Number two, we underplay the complication rates of ERCP. If you are already perforated, and if you go on to do a ERCP, and if you create a complications like serious complications like pancreatitis in that patient, or create another perforation there, bleeding there, then it more complicate the procedure more. My question to you is that you said type 2 peribacterian procedure perforation can be closed with SEMS and clips. many times when we are using a pre-cut needle, we haven't cannulated the bile duct. So you will not be able to close such perforation with a clip or a SEMS. If we have already cannulated and created a perforation later on, then whatever you said during your talk can be applied. If you haven't cannulated, it is a very complex procedure, then what do we do in that case?
First thing, as far as the perforation goes, I went through many literatures. Wherever they have created perforation, there was maximum attempt to complete the ERC because this patient has basically come with obstructive jaundice, pain, polonitis. And various series have shown that success of completing an ERCP even after perforation was around 80%. 20% of the time they were not able to complete ERCP, and these patients underwent direct surgery with CBD exploration and teeth replacement. And as far as perivitalian perforation is concerned, here also again it is paramount that we complete at least stent placement. If we fail in placing a stent, then just we have to put a nasogastric tube and pray for good. Otherwise the patient is going to develop retroperitoneal leak, is going to develop abscess, which is going to prolong his stay with need percutaneous drainage. Sometimes it can move on for surgery. If we cannulate, well and good, we put SEMS, first option. Using clip in that location again is going to be a challenging task because we will not be able to get the clip with the angulation. Yes, if possible we can do a nasobiliary tube. Nasogastric tube will two things. If the patient undergoes surgery, they put retrograde jejunostomy tube. Feeding jejunostomy is put retrograde to get the biliary drainage away from the duodenum. Correct. So there will be some amount of gastric reflux, and even the gastric, it is imperative that we put a nasogastric tube. So that is what, as far as.
So now there are many people are using anti-obesity drugs like liraglutide and semaglutide. These drugs should be avoided in patients suffering from gastropathy. This is one point. Another one is global. When you recommend Udal insulin medication or Osetic insulin medication? Udal insulin medication and Osetic insulin.
I am not aware of those two techniques.
Gastroplasty and gastropexy.
So only here to talk about the endoscopy, sir. Just wanted to highlight the surgical aspect of GERD. So I am not an expert in surgery. So we are glad to have our opinion from surgeons. Thank you.
The last question or suggestion from regarding the PCAS. So we have been using for the past 2 or 3 months. So it was not being very well studied in Indian patients. So what I feel is, so it is it's not going to be a TPA replacement, but definitely there is a role which it can replace resistant exfoliatory treatment in the future. Running out of time, we are finishing the session.
Thank you, sir, for this wonderful session. Thank you, chairpersons and speakers.
கண்ணும் கதை பேசும் கந்தனாய் கருத்தோடு கலையை கூறும் அழகனாய் வெற்றியினை வேரோட்டும் வேலனாய் நம் தமிழும் முருகனும் தலைப்பில் ஆட வருகிறார்கள் நர்த்தனர் ஆண்கள் பரதநாட்டிய குழு குரு டாக்டர் ஜெயவீர பாண்டியன் பேராசிரியர் தமிழ்நாடு அரசு இசைக்கல்லூரி திருவையாறு. My kind information is not ready.
Video open on the
Everyone kindly take your seats.
நம் தமிழும் முருகனும் கழிப்பில் ஆட வருகிறார்கள் நர்த்தனர் ஆண்கள் பரதநாட்டிய குழு. குரு டாக்டர் ஜெயவீர பாண்டியன், பேராசிரியர், தமிழ்நாடு அறக்கட்டளை கல்லூரி, திருவையாறு.
அவன் மறுமுகனாய் சிரித்தான்.
சரவண பூக்களத்தில் ஆறு மதலையாய் உதித்தவனா, சரவண பூக்களத்தில் ஆறு மதலையாய் உதித்தவனா, மலரனை தாயோரி அவன் மறுமுகனாய் சிரித்தான். மலரனை தாயோரி அவன் மறுமுகனாய் சிரித்தான். சரவண பூக்களத்தில் மாறு மதலையாய் உதித்தவனா, சரவண தாயோரி அவன் மறுமுகனாய் சிரித்தான். சரவண பூக்களத்தில் ஆறு மதலையாய் உதித்தவனா, சரவண தாயோரி அவன் மறுமுகனாய் சிரித்தான். மாங்கனி வேண்டி நின்றான் உலகை மாயின் மீது வந்தான். மாங்கனி வேண்டி நின்றான் உலகை மாயின் மீது வந்தான். ஆண்டவன் ஆணை முகன் வெற்றிடத்தால் விதேகம் கொண்டான். ஆண்டவன் ஆணை முகன் வெற்றிடத்தால் விதேகம் கொண்டான். மாங்கனி வேண்டி நின்றான் உலகை மாயின் மீது வந்தான். ஆண்டவன் ஆணை முகன் வெற்றிடத்தால் விதேகம் கொண்டான். சரவண பவன் புகழே சரவண பவன் புகழே
பிரணவ உருடரியா அந்த பிரம்மனை சிலையிட்டான். அரணவன் உருவாக வந்து பிரணவ உருவான்.
பிரணவ பொருளறியார் மனை சிறையிட்டான். பிரணவ பொருளறியார்
ஆவலாய் அவ்வையவள் தமிழை ஆனந்தமாய் கேட்க நாவல் தனிப்படத்தை சுழற்சுழல் தமிழ் சுவைதான்
ஆவலாய் அவ்வையவள் தமிழை ஆனந்தமாய் கேட்க ஆவலாய் அவ்வையவள் தமிழை ஆனந்தமாய் கேட்க நாவல் கற்பழத்தை சுடச் சுட நல்கி தமிழ் சுவைத்தான் நாவல் கற்பழத்தை சுடச் சுட நல்கி தமிழ் சுவைத்தான் நாவல் கற்பழத்தை சுடச் சுட நல்கி தமிழ் சுவைத்தான் நாவல் கற்பழத்தை சுடச் சுட நல்கி தமிழ் சுவைத்தான்
பதம் சூட்டி அருள் செய்தார்
அவயக்கரம் தூக்கி உபயபதம் சூட்டி உவந்தருள் செய்வீரா அவயக்கரம் தூக்கி உபயபதம் சூட்டி உவந்தருள் செய்தார் கரமலர் மேலேந்தி கராமமை மீது புறமலர் குஞ்சரியை மலவழித்தான் வேலன் கரமலர் மேலேந்தி கராமமை மீது புறமலர் குஞ்சரியை மலவழித்தான் வேலன்
was so great. Thank you so much.
challenges in AMH. I would also like to acknowledge and welcome our esteemed chairpersons for this session. Dr. Sabu Jayasekharan, Kanish Rai, Babu Kumar S, Dr. Ilavarasi N, Dr. P.N. Kavita Devi.
I kindly inform you that tea is available here. If anyone wants, they can take tea.
I request the chairpersons to kindly come on to the dais. Dr. Sabu Jayasekharan sir, Dr. Kanish Mohammed sir, Dr. Babu Kumar sir, Dr. Ilavarasi ma'am, Dr. Kavita Devi ma'am.
Please join me in welcoming Dr. Sangeeta Dhanraj ma'am to the stage.
Good evening everyone. Thank you for the opportunity. At the outset, I would like to thank the council for inviting me today. Professor Kandasamy sir called me very kindly to ask me to talk about diagnostic dilemmas in autoimmune hepatitis. I was trained in the UK and most of my experience is from the West, but I will share you my perspective today. Autoimmune hepatitis is one of an age-old disease that has been around since the 1930s. It is one of the first liver diseases for which an effective corticosteroid treatment was convincingly proven in many clinical controlled trials. And 75 years later down the line, it still poses a great challenge to diagnose and treat the condition. The American College defines autoimmune hepatitis saying that it does not have a single signature diagnostic feature, and the diagnosis requires the presentation of constellation of features which varies from patient to patient with the same clinical condition. The European group says it is a large heterogeneity of clinical, laboratory and clinical manifestation. Prevalence is about 15 to 25 cases per 100,000 inhabitants. Commonly affects women, and there is a bimodal distribution which peaks usually around the puberty and the 40s to 60s age group. It is imperative a prompt and a timely diagnosis should be ascertained as soon as we can, because if left untreated, it carries a very high mortality rate. It is important to note that most of the patients presently, i.e. 50% of children who present to us have cirrhosis, and 1/3 of adults at presentation have cirrhosis too. My task today is to focus more on the postgraduate students to give them a very simple and a practical approach to help them diagnose or suspect autoimmune hepatitis in a clinical setting when they come across such patients. We know it's a non-resolving chronic liver disease that mainly affects women. It is characterized by hypergammaglobulinemia with the presence of circulating autoantibodies, association with HLA-DR3, DR4, with typical features on histology and a favorable response to immune suppression. 1/3 of them have very slow progression, i.e. they are asymptomatic at presentation. Another third of them present to us with acute hepatic features, and 1/3 of the patients present quite late in the disease stage. In an acute presentation, it is important to note that the serum immunoglobulin G levels can be normal and autoantibody screenings can be negative too. As per the natural history, we all know that a better treated disease has got a good prognosis compared to the untreated ones. Why is the diagnosis difficult? Because it is an autoimmune condition, it can overlap with other autoimmune conditions, particularly PSC, the PBCs, the variants, the DILIs, viral hepatitis, so on and so forth. However, this can also give us a clue in diagnosing the condition. As an immune-mediated disease, it can be associated with other immune-mediated disease, by which I mean if a patient present to us with whom we suspect autoimmune hepatitis, presence of a celiac disease or diabetes or rheumatoid arthritis can give us some clue towards picking up a diagnosis of autoimmune hepatitis in such groups. And always take a careful family history because 40% of first stage relatives seems to be affected by this condition. Autoimmune hepatitis seems to have associated with hepatic and extrahepatic malignancies and some non-melanoma skin cancers too. The International Autoimmune Hepatitis Group came up with a scoring system which was initially very complicated. It had a lot of parameters and it was too difficult to apply in a clinical setting. Subsequently, they revised and gave us simplified criteria which has the core features like autoantibodies, immunoglobulin levels, the features on histology, as well as absence of viral hepatitis history. This was slightly applicable. However, it did not fare well in patients who have cholestatic liver disease or fatty liver disease and hence less used. When a patient presents to us with a transaminitis, i.e. a raised ALT, which could be just outside the upper limit of normal or can be raised to up to 40-50% with the upper limit of normal, then you start suspecting a diagnosis of autoimmune hepatitis. In such patients, the first line would be to check the serum immunoglobulins. In the West, we do all the serum immunoglobulins, but I do understand there is a cost constraint here. So unless we are very good in excluding AMAs or viral hepatitis or chronic hepatitis, we recommend only IgG testing in such patients, depending upon the availability and the resources in your hospital. If there is any coexisting hemolysis, then think about Wilson's disease too. Indirect immunofluorescence is the test that is recommended, or the test that is recommended to do the antibody testing. ANA and SMAs are hallmarkers in the diagnosis of autoimmune hepatitis. When you come across a patient who has positive ANA, always do a dsDNA level to exclude lupus in such patients. It is important to know that lupus does not cause inflammatory hepatitis. SMAs are present in again 90% of the patients, but they are not very specific too. The LKMs not only have a role in diagnosing the patients with autoimmune hepatitis, but they also give us some clue about prognosis and severity of disease in such groups. The SLAs are more useful in that it's got a very high diagnostic value, but it is not the first line test that we recommend to do in suspected autoimmune hepatitis. It is said that the positive demonstration has got a very high diagnostic value. However, a negative disease does not exclude the autoimmune hepatitis. First, we understand why it is so challenging to arrive at a diagnosis of autoimmune hepatitis based on blood test alone. Now, there are other antibodies like AMAs, Priyankas, which can be done too. The ESL group gave us a very simple algorithm in a patient pathway management. So basically, it says if someone presents to us in a clinical setting with whom you suspect a liver disease, do the basic liver enzymes. If there is a predominantly hepatic pattern or a transaminitis, then do your autoantibody screens and serum immunoglobulin levels. If the ANA, SMA, LKMs or SLAs are positive, then consider a diagnosis of autoimmune hepatitis and proceed to a liver biopsy. The important point here is, if the test is negative but your suspicion is high, they recommend doing it in a different laboratory. Liver biopsies are hallmarks. They come with their own challenges. If the patient presents an acute liver failure, then it becomes very tricky to do. However, they do have some pathognomonic features, interface hepatitis, and also dense plasma cell infiltrates. It is very important to have a friendly histopathologist. They can give us a histology activity index, which is a scoring of the necroinflammatory activity. So this not only helps in the diagnosis, but also gives us idea about the severity of the disease, thereby helping us to guide management and predicting prognosis. Now, negative autoantibodies does not exclude an autoimmune hepatitis. 10 to 20% of the patients do have negative autoantibodies. In such patients, a response to therapy can confirm a diagnosis, although it might be a bit too late for us when they present acutely. Okay, thank you. in summary, I will not take much of your time. I need just a couple of minutes. My take-home points are: when someone presents to us with an abnormal transaminase levels, please check the serum immunoglobulins and autoantibodies. If they are normal or negative, check the PMCOS or the SLAs. If they are positive, then consider a liver biopsy. In the presence of interface hepatitis and with a constellation of other features, by which I mean biochemical, laboratory, clinical features with the family history, and the presence of other autoimmune conditions, then the suspicion of autoimmune hepatitis should be much higher. Thank you.
Thank you, ma'am, for the insightful and comprehensive session on the diagnostic challenges in autoimmune hepatitis.
Now we move on to our next session, which will focus on post-liver transplant patient care, a topic that is critical to the long-term success of liver transplantation. We are honored to have Dr. Joy Varghese sir as the speaker for this session. Dr. Joy Varghese sir is the Director of Hepatology and Transplant Hepatology at the Institute of Liver Disease and Transplantation, Gleneagles Global Health City, Chennai. Let's warmly welcome Dr. Joy Varghese sir to take us through this crucial topic.
Good evening to all. It's my pleasure to be here. I'm here to thank Dr. Sundasamy sir and Shafiq for inviting for our Tamil Nadu ISG meeting. Next slide, please.
Slide so.
The post-liver transplant care. So I'm going to talk in the next 10 minutes of basics. So most of the post-liver transplant, so we fit into the complications. Based on that, our care has to be lowered. Only the rejection, second sepsis, then we are giving immunosuppressive drugs. So there related complications and the drug interactions, and based on the disease. So for what purpose we are doing liver transplant? HBV means there is a chance of recurrence. HCV, chance of recurrence. Autoimmune disease or overlap, chance of recurrence. At CC, there is a chance of recurrence. So the recurrence we have to follow it up. Then finally the graft versus post. So I will go to the early post-transplant. Suppose liver transplant, mostly the enzyme derivation post-operative either may be due to rejection or it may be allograft dysfunction. It is not a rejection, but the quality of the organ, the graft is not good. That will show the transaminase. Other things, the sepsis, it may be bacterial or viral or fungal. So mostly due to the immunosuppressive drugs, opportunity infection. There is a surgery related to complication, bileck anastomosis. Usually daily post-transplant will be the bile, that related glioma, that related to the complications. Vascular complications. The anastomosis will be in the portal vein to portal vein. There is a chance of thrombus, hepatic artery thrombus, hepatic vein anastomosis with IVC. There is a hepatic vein thrombosis, so vascular. Renal dysfunction, either due to the already the existing some intensive renal disease or they will be aggravated by the immunosuppressive drugs. This are the early immediate post-transplant period we will see. The allograft dysfunction. So first is the PNF, primary non-functional. It is a rare, it is not a common. Primary PNF, primary non-function of the graft means the liver, even after transplant, first day itself, it will show completely like the ALF pictures. Enzymes will go in thousands, INR will go unrecordable, lactic acidosis will be high. So, more or less, PNF means they need retransplant. Second is the early graft dysfunction. It is not the immediate after transplant. The LFT will be okay, normal, but over the period of time, within 7 days, slowly the liver enzyme will start to go high, bilirubin level will go high. That's called early graft dysfunction. Third is the rejections. So rejections we know, two types of rejection. Either T cell mediated rejection, that is more common. Second is the B cell mediated rejections, humoral antibodies, that is rare. So the rejection, If the same rejections happens 6 months later, that is called late rejections. Then finally is the chronic rejections. So the difference between acute rejection and the chronic rejection, once the patient over the chronic rejection, it is almost like a irreversible. The duct loss, whatever histologically we are going to see in chronic rejection, it will persist. So most of the time chronic rejection shouldn't happen. Normally the chance of getting chronic rejection will be less than 2%. Once the chronic rejection over the period of time will go to, the patient might get retransplant. But acute rejection completely reversible. PNF, I already told, the patient's graft, either cadaver or living donor. The reason no one knows. So why suddenly the graft, quality of the graft suddenly gone irreversible, functionless. So they need immediate retransplantation, very difficult, this all the changes. Yearly allograft function, there is a definition, is that. So normally the 7th POD, if you are seeing the bilirubin is more than 10, INR, if it is more than 1.6, we have to anticipate it is the yearly graft. It is not a rejection. So the reason for yearly allograft function is various. Either the organ quality related, if you are going to put a fatty liver, if you are going to put a elderly age groups liver, 70 years, 80 years old cadaver liver, or even living donor, the percentage, whatever we are taking, it's not adequate volume of the liver. So many factors will be involved. And another thing, the ALT. So these all mostly will cause yearly allograft dysfunction. The treatment for yearly allograft dysfunction mostly is supportive care, and most of the patient will die due to the secondary sepsis. So the patient might require the close monitoring therapy. So these are the risk factors. So many things, mostly the donor related, few with the recipient related, and intraoperatively. Suppose the more and more the prolonged period of the intraoperative time, or the multiple transfusion, or the transferring the organ from one end to another end, the prolonged the cold ischemic time. So most of the factors will influence the yearly allograft dysfunction. So yearly allograft dysfunction we can anticipate, but at the same time, better we have to go for preventive measures. Otherwise, ACR I told, T-cell mediated inhibited in the rejection. So there will be the classical ACR. I don't want to go in detail. So what the histology wise, the port, just to remember the portal triad, the portal vein will be there, bile duct will be there, hepatic artery will be there. Bile duct, there is a ductulitis picture. Portal vein, there is a venulitis pictures. The hepatic artery branch will be the arteriolitis. So out of these three changes, if the two is there, then we can say it is the ACR surrounded by the inflammatory inflammations. So for that treatment, we know we have to start with the injection methylprednisolone. If the patient fails with the steroid therapy, second dose of methylprednisolone, still the patient goes to this is called steroid resistant ACR. We can use the ATG and the basiliximab, some other. So whenever the steroid resistant ACR, is more chances to progress to the chronic rejection. So then we have to always, when a patient develops the ACR, that particular group should be on slightly higher immunosuppressive drugs than the non-ACR group. So most of the patient might require tablet bisolone, 5 mg or 10 mg along with the rest of the immunosuppressive drugs rest of the life. So, okay, so antibody mediated rejections. So the antibody, so ACR T-cell mediated. So antibody means B-cell mediated. So the B-cell mediated means we know immunoglobulin or complement factor mediated. So that time we can see the IgG4 related changes. There are the CD4B, the kind of some markers are there. Histologically, we can see that kind of the complement, the factors, the infiltrated changes in the arterioles. So antibody mediated rejections. So here we can see the C4b deposition as well as the donor specific antibody. So donor specific antibody, to know, we have to collect. Suppose we are going to do the living donor transplant, we can call the donor and we can collect the blood sample, we can get the recipient blood sample, we can send to the lab and we can ask whether the donor specific antibody is still there in the post liver transplant phase. Suppose the cadaver means, how will you get the donor? Because already the cadaver after donation they will go further as well. So there is a very difficult to do the donor specific antibody in DLT setting. So that time we will only depend on C4b deposition in the liver histology. So it will show the picture. So that all the total capillaries will be the C4b. Once if we knows, that is called AMR. So ACR, T-cell mediated, I told you the treatment of choice will be the steroid, pulse therapy and the ATG, etc. But AMR also, more or less, the treatment is same. So we have to give the steroid therapy. And the problem with the AMR, if the response is not like ACR, so it will also be fail to treat, it will go to chronic rejections. And the complication, the post-vascular hepatic artery thrombus, if you identify, it's a chronic hepatic artery thrombosis, this is all acute. Then we have to redo, we have to re-explore hepatic artery dissection. Sometimes it will go up to the celiac tract, even the aorta. So that is the life threatening. That time we have to go further, stenting into the portal vein thrombus. Early weeks we have to redo. If the late portal vein thrombus, mostly like the EHPO, the keraroma will form. So we don't need to do anything. And we don't need to give the any low molecular weight hepatic and other things. Hepatic vein thrombus, acute means we have to re-explore, and if it is slowly happening in the percavillary, this group might prepare the low molecular weight hepatic. Infection part, so I will cover quickly. So there are the bacterial, viral and other things, fungal, there are so many the risk factors are there. But among the post-transplant, cytomegalovirus infection is the most common. That's why all the post-liver transplant patients will be on the valent encephalopathy prophylaxis, irrespective of the donor or recipient positive or negative. So it may be the viremia or it may cause any invasive basis, suppose CMV colitis, CMV esophagitis, CMV hepatitis, so many things. So, and pneumonitis. When the post-liver transplantation, whenever you are going to do endoscopy or colonoscopy, even if there is a erosion like, we have to take a biopsy. The biopsy we have to send it for the presence of any inclusion bodies are there or not to rule out the things. Most of the CMV related infection will be even those within 6 months. Very rarely we are seeing the 6 months after the post-liver transplant period. So the treatment, if you identify that, because I used to go these are there. And the treatment is we have to go for the injection, the ganciclovir or valganciclovir, that will give the complete cure to the patients. So the PCR we have to do the things so we can quantify, and the P65 antigen is one of the key for the CMV infections. So next. The herpes, so I will stick to some key point. Herpes zoster, even we are giving the before transplant the vaccine for the herpes zoster, varicella zoster, right? But still there is a chances post-liver transplant patient within the herpes zoster. That time we have to treat the patient like similarly how we are treating the like acyclovir with high dose. And sometimes the herpes may be localized or it may be cerebral. EBV virus is common in the, not I will say, not uncommon in the pediatric liver transplant, mostly because the PTL, the post-transplant lymphoproliferative disease. So once if we diagnose the EBV, the post-transplant children become with the lymphadenopathy, and we have to send for the viremia test. If it comes positive, The treatment here, we have to stop all the immunosuppression or we have to reduce the immunosuppression. Otherwise, if we go to extensive disease, very difficult to save the child. That is regarding the EBD. Accessory, it's not a common, but if you get again sometimes with the genital area or something the oral area, we have to treat with the routine acyclovir treatments. So regarding the immunosuppressant side effects, so we have to think about the drug interaction in the patients on ATT or anti-epileptic drug, and the tacrolimus, only the neurotoxicity or renal dysfunction. If the patient had one neurotoxicity problem with the tacrolimus, he can switch over to the cyclosporine. That is the treatment. We shouldn't completely stop the tacrolimus. Same way, cyclosporine related neurotoxicity times, even though both are come in the CNA group, we can switch over within that groups. And the everolimus, mTOR inhibitor, we have to see the dyslipidemia or proteinuria, because the diabetic patients, proteinuria is there. If you are giving the everolimus, the patient few months later will come up as anasarca due to the significant proteinuria. That is very low nephrotic syndrome, very difficult to treat. And the microfilament prophytic, so most of the GA disturbance. Steroid patients, so mostly we will give a lifelong steroid immunosuppression for the autoimmune etiology or the overlap syndrome, or those that have the recurrent ACR. That time the patient might get, so better to use the very low dose. That time the chance of the complication will be there. Renal dysfunction, so routinely we have to reduce the immunosuppression. Biliary complication, endotherapy is the treatment. Mostly weak, I said, but in the late complication, later in the late period, the strictures are common. If the patient has the AMR, the antibody mediated recession, the stricture will be the intrahepatic multi-level, so that is very difficult to manage with the patients with the intervention radiology. Very rarely you will see the biliary cost of the things, and complications are more with the living donor liver transplant, is the biliary complication or vascular complication than the VDLT, because as we are going to use a right lobe or left lobe, the diameter of the depth will be the much lesser than the routine VDLT. The last slide is the graft versus host. So far I told you the rejection means our body immune system act on the implanted liver, it is causing damage. In graft versus host, it's a reverse way. The implanted graft will act on our body immune system. So the liver function will be normal, but the patients will develop the skin reactions, totally the skin rash and the erythema like things. They will get the pancytopenia because it act on the bone marrow suppression. So finally they get a sepsis and they will die. The graft versus host disease common in the bone marrow transplant, but the liver solid organ transplant, liver transplant is less, but it is really challenging. And the retransplant, certain indications are there, as I told, primary non-function or the failed graft or the chronic rejection, and the more common the recurrent disease and other things. Thank you, sir. Thank you so much for attending.
Thank you, Dr. Zoology, sir, for the highly informative and comprehensive session on post-liver transplant patient care. We now invite our chairpersons to share their thoughts on the session.
Thank you, Joy, for your excellent lecture. Which type of rejection is more common?
ACR is more common. Usually ACR is 40 to 50% of the patients. So don't think a patient gets the post-liver transplant period, the rejection, it is uncommon. Almost 40 to 50% of the patient will get. The reason is maintaining the low immunosuppressive. Better in our population, I will say ACR is easily manageable than the sepsis complication. You start with the low immunosuppression. Even if you get the ACR, we can step up the immunosuppression, we can manage. Instead of that, giving that to avoid the ACR, giving the adequate immunosuppression. Once it gets a sepsis, most of the patients will go for multi-organ problem.
transplant, what is the protocol for immunoglobulins and how do we handle that?
So nowadays the hepatitis B post-transplant, we are not using the hepatitis B immunoglobulin. Earlier period, intraoperatively we have to give, and immediate post-op period we have to give, we have to keep the anti-HBs antibody titers more than 100 IU. The loss of that earlier, but nowadays mostly no need of any hepatitis B immunoglobulin. Because most of the patients will be on the oral antiviral drugs, either the nucleoside or nucleotide analog, and we have to continue the oral antiviral drugs irrespective of the HPV DNA level pre-operatively. So they're lifelong. At present, we have to continue lifelong.
Thank you, Dr. Jai. It was a nice lecture. And nowadays, liver transplant is so common. Almost everybody needs a patient who has a transplant or various other diseases. And thank you so much for sharing your knowledge here.
Joy, what is the ideal TAC level post-transplant and how long to?
So immediate post-op period, that means I can say first to 4 weeks, we can keep between the 6 to 8 nanogram per year. But if the patient, if we are thinking there is a more prone to get a sepsis, because ACLF, you do the transplant, they are more prone to get the post-operative count. At that time, better maintain between the 5 to 6. But if you go ahead for the after 3 months and other things, slowly we have to reduce. And 1 or 2 years later, the TAC level we can keep between 3 to 5.
Thank you, Joy. With this, we wind up the session. Thank you very much.
Thank you, sir. Thank you, sir, for the speakers and the chairpersons. Now going on to the next session.
Next on our agenda is a highly engaging panel discussion on the topic large CBD stones, lab CBD exploration versus ERC. A case-based discussion that will delve into various approaches to managing this complex condition. Moderating this session is Dr. R. Ravi sir, an accomplished gastroenterologist with extensive expertise in ERCP, diagnostic and therapeutic EUS, and advanced procedures like third space endoscopy, including POEM, FNP acquisition, and celiac plexus block. We are also honored to have a distinguished panel of experts, including Dr. Kannan M, Dr. Shivashankar, Dr. Sarvana Bhupati P, Dr. Raja S, Dr. Revati MS, Dr. Bennett A. Duresami, Dr. John Griffith. With such a knowledgeable panel, we are sure to have an insightful and comprehensive discussion. Without further delay, let's hand it over to Dr. R. Ravi sir and panelists.
So, good evening everybody. So, thanks the ISG for giving this opportunity. So Dr. Kandasamy has given me the job that I have to make the surgeons say that ERCP is the only treatment and surgery should not be done for CBD stone. That is what Dr. Kandasamy, and that has to come from the mouth of the surgeons. So I have a very expert, knowledgeable panel which consists of 3 surgeons and 3 physicians. So first, I'll ask Dr. Raja. We know ERCP is the gold standard for treatment. So, and what are the difficult CBD stones, Dr. Raja? Right?
Yeah, for gallstones, ERCP is the gold standard treatment. The difficult stones are depending upon the size. If the stone size is less than 15 millimeter, the location is in diabetic or cystic duct, and the large multiple stones and short CBD, and there is a structure above the stone, and the good angulation of the CBD.
Thanks, Raja. So, difficult CBD is a stone which cannot be removed by a single conventional ERCP session with simple methods like biliary sphincterotomy, balloon or basket extractions. It can be due to both stone characteristic as well as bile duct. As Dr. Raja said, all this diameter which is more than 1.5 centimeter, multiple stone, unusual shape, hard stones, location, and bile duct factors. All makes a stone very difficult for endoscopic removal. I'll go on to Dr. Revati. And what is a large CBD stone? Is there a special size which makes them large? And why do we need to know whether a stone is large or small?
Of course, the large CBD stone is based on two criteria. One, the size of the stone. If it's more than 1.5 millimeters. The other one, 3 or more stones of 1 centimeters clubbed together in the bile duct. So with these two criteria, we can call them as large CBD stone. And why do we know about the CBD stone size? Because the smaller stones we know can come out spontaneously. A medium-sized stone, of course, by conventional ERCP, sphincterotomy, and by balloon extractions. Larger stones is a very complex process, as you already said. It not only depends on the size, but also the shape of the stone, the anatomy of the bile duct, and where the stones are present, either in the confluence or as an impacted stone or in the intrahepatic stones. All these factors play into play, for removing the CBD stone. But ultimately, two things have to be focused. One, either we make the passage bigger, we expand the passage for the removal of the stone, or we need to crush the stone. So for that we need to know the size of the CBD stone as well as bile anatomy, biliary anatomy.
Thank you, Dr. Revati. So Dr. Kannan, so last CBDC, largely said what are the difficulties you will face. So if you have a large CBD stone, which you think cannot come by simple sphincterotomy and balloon extraction, how do you prepare yourself for ERCP?
We have adequate instruments like the sphincterotomy balloon required mechanical laser, also zinc laparoscopy. We have adequate expertise also in the managing the large CBD stones. Also surgeon backups, not able to remove the stone, you have to ideally, suppose if you can remove the stone, you have to do the surgery.
So what are the main principle, as Dr. Revati correctly said, expanding the stone passage, distal bile duct, and reducing the stone size. So we generally prepare with routine accessories, whatever we need for ERCP, and it is wise to have lithotripsy devices. There are many important ways that lithotripsy devices, mechanical, laser, and electrohydraulic. At least one should have one or two of these before attempting an extraction of large stone. So how do we make how do we make the passage bigger?
Depends on the stone size and the noise diameters.
So what do you think about, there is a large balloon dilatation of the sphincter and mechanical lithotripsy. What is your opinion about large balloon dilatation? So how much can you dilate the sphincter?
More than 15, more than 10 to 15.
So basically depends on the size?
Depending on the size of the stone and the lower CBD diameters. And also adequate margin, 10 minutes adequate adjustment.
So we can dilate the so this is a sphincteroplasty is a procedure which is primarily used to expand only the sphincter. One shouldn't dilate the lower CBD to more than a millimeter of its current size. If you dilate it to more than 2 millimeter of the bile duct, generally it results in bile duct rupture. So one should not make an attempt at dilating the bile duct to more than 1 or 2 millimeter of its current size. The number two is when you are doing a balloon dilatation, it is always important to see that the stone is not on the side of the balloon. If you have a stone on the side of the balloon, then along with the 10 or 12 millimeter balloon and the 12 millimeter stone, we will expand the bile up to 20 millimeter, which will definitely result in rupture of the bile duct. So one should be careful, but there are some complications happen because of endoscopic large. Anybody want, Raja? Do you want to talk about complications of large balloon dilatation?
The patient will have severe pain, bleeding, pancreatitis, and sometimes perforation.
So perforation. So particularly if perforation happen in this after a balloon dilatation, large balloon dilatation, we will not be able to deploy a metal stent and close it because we have already dilated it to 15 millimeter, and the currently available fully covered metal stent which are deployed for closure of perforation are only 10 millimeter. They won't stand there, they will migrate. So when we come across with the perforation here, an attempt should be made to close with the clips. If not, surgery should be done. And pancreatitis is one of the early complications which happen when at the time of introduction of these balloon dilatation, which resulted in 2 deaths in the first 2 cases. So later on we learned that if we do a moderate sphincterotomy and then do a balloon dilatation, pancreatitis doesn't happen. If you do it without sphincterotomy, pancreatitis is one of the serious complications in this large balloon dilatation. So, this is a large papillary balloon dilatation. So one should be very cautious that the stone should not be on the side of the balloon. So what about basket? Lithotripsy. Anybody want to say something about lithotripsy? Mechanical lithotripsy?
This is an older method of, it's been practiced even now, mechanical lithotripsy. But for the basket, you should hold, you must do the crushing so that the fragments are held in the basket. You see to that it is inside the basket.
Dr. Raja, do you have any, what about different, there are different lithotripsy baskets which are available. Most of them are through the scope. The currently, after the introduction of the current smaller lithotripsy basket by Boston, the newer students have stopped seeing the old bigger lithotripsy basket. Lithotripsy basket can be applied through the scope as well as outside the scope. Have you ever used, Raja, have you ever used emergency Sugendra lithotripta?
1 or 2 times I have used it.
So nowadays it has become a rare event. We used to, I always used to carry that along with me wherever I go for years. If I cast the basket and I cannot crush, I take out the scope, and this is a bigger Sugendra lithotripta. Even now it is available, but people, this after the introduction of the Boston lithotripta, this lithotripta as a tip, if this basket doesn't close strongly and crush the scope, the tip will give away, and then you can remove the basket. Previously, all this lithotripta basket, if we cannot crush the stone, it will get caught inside the bile duct. So we cannot remove this basket, and then we will be in a trap. you have to sacrifice the basket, remove the scope, and then send them for surgery. So
Use length in that case.
yeah, we have to, if we have pulled the stone down and impacted the stone, then without driving the buildup, if we come, then they will develop a colitis. Either we need to put a stent or ask radiologist to put a percutaneous drainage. Then there are now currently new methods available. What we currently do is that this is caught inside the basket. So ESWL can be very easily done on this stone, or we can sacrifice the basket, reintroduce the scope, use a spyglass lithotripsy and laser lithotripsy and remove the stone. Currently these are available, but these things are not available in every center. So if lithotripsy, the stone is very big, the chances of failure is high, and then impacted stone, and the CBD diameter is less than the stone diameter, then sometimes we cannot cast the stone in the basket. So there is a patient who has a history of lap cholecystectomy in 2021, asymptomatic since then, and she presented with fever, pain, and jaundice. And this is the MRCP. And Dr. Griffson, will you ask the patient, or will you do surgery on her?
So this patient has got a dilated CBD, probably I think it's more than 1.5 or 2 centimeters, and a large stone, and has presented almost 3 years from cholecystectomy. So it's a primary CBD stone that has occurred. So and the patient is in cholangitis, so I think initially we'll manage with the antibiotics. If it's stable cholangitis, patient settles down, then I will do a laparoscopic exploration on this patient, because most of them will need a biliary drainage procedure as well. Otherwise the chance of recurrence is going to be very high. If the patient is in severe cholangitis, has got some organ dysfunction, then we will put across a stent. I will refer to a medical gastro and later do a procedure.
But then this patient already had a cholecystectomy. There is only one stone. Don't you think your medical colleagues can manage it completely?
Several studies are there which shows if the CBD diameter is more than 15 mm, especially in the setting of post-cholecystectomy, the chance of recurrence is going to be very high, to the tune of 40 to 50%. So how many procedures of ERCP is going to do? And at the same time, the surgical drainage procedure gives a very good.
What surgery? You will remove the stone and then
do a cholecystectomy, biliary drainage. That can be done in laparoscopy.
Anyway, so a large stone, sometimes recurrence of stone is a common. So we have come across with the procedure called large. After removal of the stone or before, we do a balloon dilatation that reduces recurrent stone formation. Suppose, but this stone has a shape which is square at the bottom. If you see the stone shape, it is very sharp square. So this is quite difficult for removal through just ERCP. But then if we use but it has a space around the stone is not impacted, so we can either do a lithotripsy, particularly if it is a primary ductal stone, the stones will be soft. So Dr. Kannan, do you agree that it's a post-cholecystectomy? So do you agree with the surgeon that
still ERCP is a service.
So you think only ERCP, not surgery?
Yes, sir.
So what about the other surgery, Dr. Bennis?
What's the size of this?
This is 1.5 across.
So we can remove it by ERCP, but the thing is, as Dr. Gibson told, that drainage is more important. The drainage, the CBD is better than the ERCP sphincterotomy.
But then we also make a good sphincterotomy. We also create duodenectomy only by balloon dilatation.
But another advantage of the CDD is when again you go for ERCP, it is used for you to replace so easily through the CDD.
So anybody has a different opinion, Dr. Ganesh? Hey, Mike.
Space around the
So you can catch it in the basket.
This is a square stone, as far as I am concerned, and the diagram also showed a distal CVD stricture, I think, is there. So there is a stricture with the stone about which is quite big in the size, more than 1.5 centimeters. I think we need to be very careful in such situations because the distal CVD stricture and stone about are very difficult to remove. ERCP might succeed, but we need to be very careful. We may land up in complications, but we can probably do a sphincteroplasty and then spyglass, do a lithotripsy using Holmium, break down the stone and then see whether you get clear. Because already a cholecystectomy has been done in this patient.
But this is a pancreatic duct. If this is a bile duct, then we cannot do a sphincteroplasty. And the bile duct is somewhere here which is not seen. So
Spyglass is probably the best approach here.
yeah, some form of lithotripsy, and when we do remove large stones, only very 1 or 2 in 100 recurrent stone. So then if you are doing a surgery, we will be doing for 100 surgery for recurrent stone. We could easily avoid surgery 98.
Surgery is not a thing which should be avoided. The surgery is the best procedure because it's already the duct is dilated, and CDD will be a better drainage procedure than your sphincteroplasty, which again can go in for a stricture, and moreover the complication rate of that procedure is also high. So I personally feel that lab CVD exploration with the CDD will be the ideal procedure for this situation because the drainage will be adequate.
So I thought if a patient has a gallbladder also, then if both can be done, then surgery is a choice. If this patient already undergone a cholecystectomy, it is only a CVD stone, which medical gastro can do it in almost 99% of the time successfully.
So the problem is not with the clearance. I know you can do a very excellent clearance. The problem is with the stone recurrence. Because these are primary stones, as you said, it's believed to be due to biliary infection, which usually is due to, they say, duodenal-biliary reflux of bile, so that produces the duodenal contents that goes into the bile that produces infection.
That is a very interesting observation, which I have an objection. If you say duodenal-choledochal biliary, the fluid reflex, choledochal duodenoscopy will always cause food entry.
That is because of the dependent position. It doesn't usually. Studies have not shown the recurrence rate, comparable to the primary stone.
Anyway, I have seen a lot of below the choledochal anastomosis. There is a small duct, some syndrome. I've seen a lot of complications following. But anyway,
large sphincteroplasty usually prevent
recurrent stone formation in most of the time.
not every time.
So now another patient, 56 years, large CBD stone, need CBD stone removal and cholecystectomy. Now gallbladder is not shown here, but now here there is a huge stone, and you can see the duct is very small below. So anybody, Dr. Raja, you want to make an attempt? Do you want to go for ERCP?
It's very difficult to do ERCP in this because the stone is more than 15 or 20 millimeters. The narrowed CP. Distal CP. So it's very difficult. At this juncture, surgery may be the options.
So what you think is this CBD below is not dilated. it is a normal duct. Above there is a big huge stone and a dilated bile duct. So we cannot call this as a stricture, but it's an undilated duct. But still, we can remove it by by ERCP method. But this patient has a large stone in the gallbladder also. So Dr. Parent, how do you do lab CBD exploration? To my knowledge, lab CBD exploration is very clumsy, time consuming. You need C-arm, you need colonoscope to complete, be sure that you have completed all removal of the stone.
This lab CBD exploration, duct is very small, it is difficult to do. But otherwise, what we used to do is, we take the help of the urologist and you open the CBD and let them put that scope inside. That is a rigid 3 to 4 mm scope, and they will remove the stones and clear it. Then we will put a stent inside and primarily close the CBD.
So, do you think it's an easy procedure? I thought if it's a flexible scope, you can go intrahepatic. If it's a rigid scope, sometimes these stones move upwards or fragment. Then it's not quite difficult.
When you do CBD, when you go through cystic duct, it's difficult. When we are going through transrectal, we can go both sides. Provided the CBD is around 8 to 10 mm.
So anyway,
in the conventional technique, what the laparoscopic exploration is either transcystic or chorioidocotomy. That is, if the stones are small, they use a cholangiogram, occlusion cholangiogram, then they detect the size of the stone, they dilate the cystic duct, then do the stone extraction. The other one is when the stone is large CBD stone, after completion of the cholecystectomy, they explode the CBD and remove it with a Fogarty or Darmia, or sometimes they use a cholecystoscope. But what we follow in Tirunelveli Medical College is we get the help of a urologist. So this was an innovation done by a general surgeon, Dr. Pratap, and this was followed by in our unit, and most of our assistants are doing it. We use a rigid ureteroscope which is passed through the epigastric port, and it is just in line with the CBD, and we remove a huge, whatever the large number of stones under the vision, and as well as you can use whatever the lithotripsy, which is the stone which they break it, and we will never miss it. We can completely visualize when we use the umbilical port to visualize the upper part of the duct system. When we use the epigastric port, we visualize the lower part of the system. Only thing is, we have to have a dilated system. We take as a 10 millimeter as a diameter, below which the rigid sigmoidoscopy will tear the CBD. Otherwise, more than 10 mm of CBD, this is one of the best procedure I have come across, and you can do the same anesthesia. And in our institution, more than nearly 25 cases of lab CBD exploration have been done, and this is not published yet. And of course, I don't do anything laparoscopically. Most of my assistants do these procedures, and we are yet to publish the data.
So, did you make a referral to the medical gastroenterology to make an attempt at removal, or even without an ERCP, you stayed away with this?
Most of these cases were failed ERCP cases, which we again did this lab CBD exploration.
See, according to you, you said the distal CBD is normal. So why don't we try balloon dilatation and then?
No, distal CBD is normal. It is not stricture. It is undilated. Normal, it is normal. But usually, sphincteroplasty cannot be done for the bile duct. It is done only for the sphincter. So you cannot use a large balloon for this. But then you can use other method. For example, laser lithotripsy. But the problem is, if you fracture this stone into 10 pieces, still each one piece will be bigger than the duct. So you will always find it difficult. It will be quite consuming. So anyway, patient require gallbladder removal. A surgery is a good option for this patient. Anyway, another patient, coronary artery disease or antiplatelet agent, abdominal pain, fever, jaundice. ERCP showed a Merisi syndrome. CVD stenting and NPD tube were inserted because of cholecystitis. Patient has started on antibiotic and IV fluids. So this is the last case. So huge stone. This is Merisi syndrome. Below doctors again not very much dilated. Above it is dilated and a large stone. And the CVD stent which was deployed in ERCP has migrated. Luckily we had put a NPD tube, so we had a biliary drainage. We were instilling antibiotic and washing through this in addition to the IV antibiotic. So what do we do, Saravanan? And do you still? Actually, I had posted this case last Wednesday for a laser litho to show here, but unfortunately because of the weather forecast, patient did not come. So surgeon wanted to do a surgery, CPD exploration. I wanted to do a ERCP. So anyway, we haven't done it. So I also think surgery will be an easy option. So what do you do, Saravanan?
Lab CBD exploration, if it is feasible by the laparoscopic surgeon, I think that would be the best option. And
open surgery?
Yeah, I am very comfortable with the open procedure. That's all. That's what I can say. I will be very comfortable with doing the open surgery in this particular situation.
So what about gifts and laparoscopy for?
I think this is looks like a tight tree. The duct erosion looks a little more. So this patient will need a hepatic jejunostomy. So probably the best option will be an open exploration and hepatic jejunostomy.
Open. What about Dr. Bennett?
Already is eroded a good part of the diet. But I think you can try the ERCP and you are able to remove all stones, probably no need for surgery. Because we are see the gap now. Otherwise, surgery is difficult. We should open it and do the hepatic jejunostomy. The hepatic jejunostomy is also difficult because already the pathology is there. The sutures may not take up. So ERCP, and if we are able to remove the stone, it is better. Otherwise, we have to go for surgery.
We will. It is in the cystic. It is almost eroded, almost completely into the bile duct. So we have to. I was originally planning a laser lithotripsy of the stone and give surgeon for laparoscopic cholecystectomy. But anyway, next week. I think time is up.
How to differentiate whether it is eroded or just compressing that we can't deal with the cholangioplasty?
No, it is if you see this, the stone is beyond the presumed duct size. The duct is somewhere here and the stone is extending beyond it, and dye is flowing only through the one side. And patient had a empyema also. So we know it's only thing is presence of empyema makes the presence of suspicion of malignancy also high. So we'll investigate appropriately. She instantly had a liver abscess, so we were treating for that. I think if there is any question from the floor to our panelists, welcome. How many of you think surgery can be done for constructs? This is a medical gastroenterology group. Nobody is raising their hand. Nobody is raising their hand.
Yes, but this is the first option, but second cases we should go for surgery.
Yeah. But in selected patients, sometimes all stones cannot be removed through ERCP. We are aware. Sometimes ERCP with such complex facilities are not available anywhere. Patients cannot afford such an expensive procedure also. It's much easier and economical to do a surgery on a patient from a distant place, Otherwise, you put a stent, they develop a collagen, stent occlusion. It's quite risky. Surgery is more morbid, but then it is quite.
Difficult CBD stones require a team of
Yes.
But in this case, the laparoscopic consultation we can do. Already the doctor and everything is merged with that. When you open it, straight away you are able to see the CBD. So, the particular region of space.
So, thank you. Your team approach is the final message for a large stone. Thank you. Thanks for the question.
Thank you, Dr. Ravi R. sir, and esteemed panelists for such an engaging and informative discussion. We now move on to our next part of the program.
Moving on to the next session, we are extremely honored to extend a warm invitation to distinguished personalities as chairpersons of the session. I welcome Dr. S. Karthikeyan, Dr. Arvind Selvan, Dr. R. Dr. R. Karthikeyan, Dr. Arvind Selvan, Dr. R. Ravi, Dr. M. Ali, Dr. Ganesh, Dr. Syed Sulaiman. Our first speaker is a luminary in the field of gastroenterology. With great respect, I request Dr. Mohammed Junaid Khan sir, Consultant Gastroenterologist and Head, Department of Medical Gastroenterology, Gem Hospital, Coimbatore, to the stage to present on the topic Genomic Profile in Chronic Pancreatitis.
Esteemed members, on and off the dais. So, today I will be talking special thanks to Tamil Nadu ISG and organizing team for giving me the opportunity to talk on this topic. I have tried to make it as simple as possible in 10 minutes time because it's a genetic topic. So let's hope that it will give for PGs to be useful. So talk is like genomic profile in chronic pancreatitis. So in next 10 minutes I will be just trying giving you the overview of the genes associated with chronic pancreatitis and its implication and what are the new tests available and what is the future of this genomic profile. So as we all know, chronic pancreatitis is a fibroinflammatory condition of the pancreas with repeated episodes of pain abdomen, multiple admission, and ultimately loss of exocrine and endocrine function in the form of diabetes or dysuria or other nutrition deficiencies. Geographically, there is a graded annual incidence of chronic pancreatitis, and in India it is something about 20 to 125 per 100,000 persons in India. So, of all the etiological risk factors which we know about, whether it is metabolic, whether it is toxic, autoimmune or drug induced, there are subset of patients who, after extensive evaluation, will not be diagnosed, will come to any etiology, so we'll label it as idiopathic chronic pancreatitis. So, with the advent or with the genome-wide association studies and family studies, these subset of patients have been found to have some genetic polymorphism leading to chronic pancreatitis. So, what is genome-wide association studies? Actually, it is a $1 billion project by the US government. Way back, I think in 20-25 years back, where they have complete DNA sequencing of DNA has been done, and that sequencing of DNA is compared in a population to find for a particular disease is there any single nucleotide polymorphism. So when the comparative studies has been done, the single nucleotide polymorphism or genetic polymorphism has been found to associated with different diseases. So it doesn't hold not only in idiopathic chronic pancreatitis, we know that it has a role in other diseases also like Crohn's disease, IBD and any disease of the human body. So this is the project which has opened the gates for further gene workup for genetic polymorphism. So what is, if you see for For PG's purpose, what is genome? Genome is nothing but a complete study of genes, its function and its interaction with itself, and its by whatever implication it is causing for proteins or this thing. So these are some of the terminology which has been used. What is epigenetic? Epigenetic terminology is like above genes. So it is something like something which can't be understood by this genome also is labeled as epigenetic mechanism. So coming on this basic, because of genome association studies and family studies, will proceed further. So there are 4 mechanisms which have been implicated in the pathogenesis of chronic pancreatitis, including first of all it is premature activation of proteases. For example, all our pancreatic enzymes are secreted in an inactivated form. Only when they come to a duodenum it gets activated. But when there is some genetic polymorphism, the activation happens inside the pancreatic parenchyma and causes pancreatic parenchyma damage, inflammation and ductal system. This activation ultimately will have stress on endoplasmic reticulum, which gives rise to misfolded protein, and this misfolded protein will lead to inflammatory cascade, apoptosis and cell death. Along with that, there is a ductal pathway destruction. When the pancreatic secretions are not properly secreted, it is not, there is a leaking phenomena which is happening because of some of the genes which are associated, and I will be telling you in future further slides. All these mechanisms will ultimately give rise to inflammatory pathway dysfunction and giving rise to changes of chronic pancreatitis. So what are the genes associated with these 4 pathways? These are the genes which are involved in this 4 pathway, which basically play a basic role of causing the chronic pancreatitis. The most common one is serine proteases, cationic trypsinogen, PRSS1, PRSS2. Then we have SPINK genes, serine proteases inhibitor, Kajal type 1. Then we have carboxyl ester lipase. Then is pancreatic lipase and pancreatic related protein lipase, cystic fibrosis, transmembrane conductor regulator genes, calcium sensing receptor genes, claudin 2, chymotrypsin activation, and then alpha-1 antitrypsin and gamma glutamine transferase. These are the genes which basically act in different levels of function of the pancreatic synapse cells and the ductal system, causing the inflammatory phenomena and the activation of the pancreatic enzymes. So what, just to come on the overview of the premature activation of proteases, PRSS gene basically controls the activation of trypsinogen and catepsin L, and it also delays the degradation of trypsinogen. So PRSS is a activating gene. Along with that is CTRC, chymotrypsin, and will activate catepsin C, which cause activation of trypsinogen into the trypsin. SPINK genes are the only one which is an inhibitory gene which prevent the activation of the trypsinogen to trypsin. So once this gene mechanism, the CTRC genetic polymorphism or PRSS genetic polymorphism get deranged, it will cause premature activation of all these proteolytic enzymes and cause the recurrent episodes of pancreatitis and ultimately lead to morphological changes in the pancreas. When this pathway is further activated by activated trypsin, which further activate chymotrypsinogen through elastase and carboxypeptidase to chymotrypsin, elastase and carboxypeptidase. So once these activated genes are secreted activated in the pancreas, you have accumulation of all the activated proteins by different genes which play a role. That pancreatic lipase will try to activate pancreatic lipase, carboxylic acid lipase will be activated carboxylic acid lipase genes, and all this accumulation of activated proteins will cause misfolding protein, which generate promote inflammatory signaling, with causing apoptosis, generating all those apoptosis pathways, leading to the stress to endoplasmic reticulum. Then there are the other ductal pathway dysfunction. For every function pancreatic choose to secrete, normally we have 2 mechanisms. One is selective secretion and absorption, and other one is prevention of unwanted leakage. So what are the genes involved in these? CFTR genes and calcium sensor receptor genes. So these basically play a role in secretion of pancreatic juices without getting activated inside the parenchyma or ductal system. Any polymorphism in these genes, which are basically this is CSR is locally located on chromosome 1 and followed by claudin 2, which cause prevention of unwanted leakage. So what genetic testing workup is required? Do all the patients need genetic testing? No, because it's only subset of chronic idiopathic chronic pancreatitis we are dealing with. So who are those patients to be worked up? Who has a positive family history? They are the pediatric patient less than 20 years. In some societies, American Union, there is a difference of age. Some say it is 35, some say it is 20. When the etiology is unclear, and in baseline, first these genes, PRSS, PINK, CFT and CRTC gene mutation should be done. So what is the advantage of doing this? The advantage is like when you try to label, you try to test the genes, and it has been identified that this genetic polymorphism is present, then you can stop the further etiology workup and you prevent the individual from other invasive diagnostic modalities, because you know the patient will going to have pancreatitis, which is because of genetic polymorphism or genomic. So the study genetic polymorphism on the basis of altered gene may aid in identifying predisposition to ECP. These are the signs which is in a very early phase, and lot of research has been going on to identify genetic predisposition and disease association and staging leading to personalized treatment protocol and medicine. So not only if we are able to identify the genetic polymorphism, we can go for gene editing also to treat those conditions. So future holds very bright, because we can go for gene editing, target therapies and personalized intervention for these particular subset of patients. So not only what is the cost of this treatment, generally in India, if you are going for genetic profile, like when you go for hereditary pancreatitis, they will roughly charge 20,000 rupees. But it is not indicated for all the patients. The patient, there is only subset of patients, the 20 or 15% who needs this. Thank you.
Thank you, sir, for delivering this delightful session.
We have two announcements to make. Regarding the quiz, we have the preliminary round today at the end of today's sessions to be held in the first floor boardroom. And today is the last day for ISG voting ballot. So going on to the next session, and it is with great respect and admiration that we recognize the expertise and dedication of our next speaker. We warmly welcome Dr. N. Rajesh sir, consultant gastroenterologist, Sri Gokulam Hospital, Salem, to converse on the topic post-ERCP pancreatitis, any pathway.
Good evening, everyone. The next few minutes are discuss about the post-ERCP pancreatitis. Is there any simple way to predict or prevent post-ERCP pancreatitis? Is there any password? Well, let me show you the password. This is a simple password. You can memorize it and you can practice. It's not that easy. Okay. Coming to the incidence, pancreatitis is the most common complication of the ERCP. The incidence is up to 10.2%. We thought it is less than 5% in the previous studies, but latest meta-analysis shows it is up to 10.2%, and the mortality is 0.2%. Because most of the patients are high, and it varies based on the geographical location. It is more common in North America compared to Europe and Asia. So the pathophysiology, the increase in intrapancreatic pressure, thermal injury, chemical injury, or proteolytic damage, secondary distribution. So the diagnosis is the new or worsening abdominal pain combined with the more than 3-4 rise in amylase or lipase within 24 hours. That is at 24 hours of ERCP. Severity is based on the Atlanta classifications, organ dysfunction or not, or duration of hospitalization. Less than 2 days is a mild. If it's more than 7 days admission, it's a severe pancreatitis. This is the important slide. It's a risk factor. It's very important. It's based on the patient oriented or it is the procedure related. The female sex less than 50 years and past history of post-ERCP pancreatitis and spectrum of dysfunction. These are the risk factors for patient-related risk factors for post-ERCP pancreatitis. Previously we thought it's a normal bilirubin, normal CVD diameter is also a risk factor, but probably that is not a risk factor. And procedure related, if it's a difficult or repeated cannulations of the PD contrast injection, pancreatic sphincterotomy, and operative experience. These are the risk factors. In fact, chronic pancreatitis is a protective. The patients with chronic pancreatitis is protective of post-ERCP pancreatitis. And more important thing is, if it is more than one risk factor, it is a synergistic effect rather than simple additive effect. So the other procedure-related risk factors, if there is pancreatic acidification during the procedure, pre-cut sphincterotomy. In fact, pre-cut sphincterotomy itself is not a risk factor. Why then the patient develop post-ERCP pancreatitis pre-cut means, if you keep on doing a regular cannulation, failed cannulation, and finally going to pre-cut, that's because of the previous failed attempts rather than the pre-cut. So, if you have a difficulty, go for early pre-cut if the anatomy is favorable. And pancreatic cytology, more than 2 attempts of PD guided passages, and balloon sphincteroplasty of intact biliary sphincter. We always cut, then do a sphincteroplasty. So, do a sphincteroplasty of the intact that produces the pancreatitis and train these bodies. So, what is the important in prevention is patient selection. This is the most important thing. If you do a ERCP unwarranted, there is no indication. You are doing for diagnostic ERCP. That is where you end up with pancreatitis. So don't do diagnostic ERCPs. Say low or intermediate probability of CVD stroke. First confirm it with the MRCP or US before doing ERCP. Suppose you are doing a direct attack, bilirubin is high, you suspect stroke, you can go directly. Otherwise, suspect is a plus or minus, go for MRCP or US before ERCP. Coming to the pharmacological prophylaxis, we all know rectal suppository is indomethacin 100 mg before procedure is there. In guidelines, the meta-analysis showed the lower incidence also, severity is also reduced after the pharmacological prophylaxis. Indomethacin 100 mg. The number needed to treat has ranged between 8 to 21 patients to prevent 1 episode of PEP. Whether to go for indomethacin or diclofenac, both are equally effective. When to give, whether the pre-procedure or post-procedure during the procedure, it is a pre-procedure better half an hour before the procedure. Whether we go for universal or high risk group, ISG recommends universal precaution, that is indomethacin for all patients, whether it's a low risk or high risk, except for contraindications like pregnancy more than 32 weeks or anaphylaxis. Whereas ASG recommends only high risk group. We use universal precaution. What about IV fluid hydration? If there is a contraindication to NSAID or cannot place a prophylactic step, then IV fluid hydration is important. We always combine with the IV fluid hydration with the indomethacin suppository. So the aggressive fluid hydration order is 3 ml per kg during the ERCP and 30 mg per kg bolus immediately after ERCP and 3 ml per kg per hour for 8 hours after ERCP. Coming to the PD stents, the pancreatic bed stents strongly recommended in high-risk patients. That is the 5 French or 7 French. We use the 5 French stents, not the 3 French stents. Placement of the stent in the body of the pancreas or tail may decrease the risk of PEP, where compared to the stent in only the head region, and stent removal is at least after 3 to 5 days, but most of them it passes on its own. We don't remove it, and we remove it during the removal of the CV stent. What about the combination strategies? Rectal indomethacin plus PD stenting better compared with the indomethacin alone. Procedure-related strategies. Limit the number of attempts of cannulation less than 5 and less than 5 to 10 minutes of cannulation. If it is delayed more than 5 to 10 minutes, go for alternative techniques. Guide your cannulation rather than contrast cannulation. And always use COT insufficient rather than air. Whether to use a blended current indicate or it's a pure cut, it's contrast still, but we use a replicate. What are the alternative cannulation strategies? Double wire technique, needle-like fluid sphincterotomy, transpancreatic septotomy, or sphincterotomy or fistulotomy. This is how we do. This is first, if you repeat the PD cannulation, place the guide wire, it's set in the angle, then you cannulate the 11 o'clock direction. So it is pancreatic guide wire, CPD guide wire. It is double guide wire technique. So this is the placing the stent. So this is the guide wire is passed till the body and tail, and then place the pancreatic septum placed over this 11 o'clock direction. You do the pre-cut, then you place the guide wire. This is commonly we do. Two things. The pancreatic stent prevents the guide wire going into the pancreatic duct. It prevents the pancreatitis. So suppose if it is going like this is going into the head region or it is going to side branch, it's not going beyond that. Whether to do a setting here, most of the times it will not stay here, it will come down. So in that instance, if it is instead of keep on manipulating here, you go for other pre-cut modalities, then go for a yes. So this is going into the pancreatic duct. So what now I am doing is cutting the sphincter from the this is pancreatic septotomy or sphincterotomy. So it is going into the pancreatic duct, keeping the right wire inside. You cut the just 2 millimeters. You cut. Can you show me? So after cutting from the 11 o'clock direction, you can take. Now it is going into CBD. You complete the procedure. It is called transpancreatic sphincter. This is hysterotomy. So suppose your knee is bulging ampulla, the capillary orifice is not visible here. So directly go with pre-cut. So the white bile is obstructed system. So you extend the sphincterotomy. So it's not enough here because I am not seeing the papilla here. So you have to go down. See, stone is impacted here. Otherwise, this foot is again impacted. It is impacted stone. Stone is removed. This is cutting from above downwards, pre-cut. So this is again bulging ampulla. Here go with that. It's easy doing a pre-cut here. This is from above downwards you go the stone. So the diagnosis is obvious, and you should have a low threshold to do a CT scan because with all pancreatitis, perforation, everything doing similar. So do early CT if you have suspicion of pancreatitis. In our experience, last 2 years data, this is from 2023-24, we have a single center study. It's 344 patients, 7 patients have pancreatitis, 2% incident, all are mild and moderate severe is nil. But previously I had 1 episode of post-gastric pancreatitis during the COVID period. So surprisingly, I analyzed yesterday, I had done a 7 PD cannulation for 344 in ISG, 20% PD cannulation. And mild pancreatitis, 7 cases, 4 cases of multiple times, 3 cases only single passage. Prophylactic stenting, I have done less cases, 16 cases only. And among this 1 case, ever pancreatitis, even after pancreatic stenting. And post-pancreatic occurred only after pancreatic cannulation, all patients. I have done pre-cut only 19 patients, out of which 2 patients developed PEP. And transpancreatic sphincterotomy, to my surprise, I have done 48 patients. And 4 patients only they developed pancreatitis. The average time for ERCP is 25 minutes. In PEP cases, the average time is more than 35 minutes. So that means prolonged time is there is chance of pancreatitis rather than the alternative methods. So we use always universal anesthetic prophylaxis. So this is a simple password. These are the first 4 alphabets of Chinese codes. First one is patient selection. Don't do unnecessary ERCPs, only therapeutic ERCPs. Second, universal pharmacological prophylaxis unless otherwise contraindication. Third is prefer guided cannulation over contrast injection and recommend early alternative methods if you are instead of keeping on probing the papilla. And finally, PD stenting if it is multiple passage. Thank you.
Thank you, sir, for sharing your valuable insights. Thank you, sir, for sharing your valuable insights and expertise with us.
As our final speaker, we are honored to welcome a distinguished professor, Dr. N. Arun sir, currently serving as Assistant Professor, Department of Digestive Health and Diseases, Keeper Medical College, as well as Consultant Gastroenterologist at Apollo Hospital, Chennai. I request him to share his wisdom on pancreatic fistulas, prevention and management.
Really great pleasure for me to be here. And thank you team ISG for giving an opportunity to be here in this discussion. And to talk about pancreatic fistula, it's such a complex area. And it's giving a multidisciplinary approach. So what do you want to make a fistulizing complication? If there is any abnormal passage being made between one epithelium to another, either through a surgical intervention or the abnormally created tract, it's nothing but a fistula. In pancreatic fistula, regarding the abnormal communication being happened between your pancreatic ductal epithelium as well as with your another epithelial surface. So what is going to happen once the pancreatic fistula gets established? There will be a leaking of secretion which will be predisposing to multiple complications in order to prevent the bleeding for further problems. And there are various classification for that based upon your anatomic location, the underlying disease process, what the disease process the patient is going to land up, or whether there is any immediate predisposing factor, for example, a gallstones or something else. What is the predisposing factor we need to look at that. And what is the basic classification anatomically we are supposed to look? One thing will be your internal fistula or external fistula. And what do you mean by this internal fistula, in which they are communicating with within your pleural cavity or within your pectoral cavity, which will be predisposing to pancreatic ascites as well as your large pleural effusion, and it could be predisposing to bronchial fistula as well as a pleural fistula, mediastinal as well as pericardial, multiple other precipitation. And regarding your external fistula, which is mainly predisposing by a surgical intervention, for example, if you are planning to do a percutaneous drainage, or if you are planning to do a PCD for psoriasis cavity, in that kind of cases we are going to develop a external fistula. Or if the patient is having any pancreatic and cutaneous fistula, if the patient is having any other intervention, is going to get covered. The predisposing main etiological factors mainly by iatrogenic post ERCP might be operating trauma, and apart from that, the injury will be predominantly in the trach, as well as if you are going to involve a tail of pancreas, splenic surgeries, renal surgeries, or adrenal intervention, or if the patient is going to have any splenic fracture mobilization. These are all the areas which will predispose to iatrogenic injuries in your, which will make a operative trauma for a pancreatic tank. Apart from the non-iatrogenic causes based upon your common etiology will be acute as well as a chronic pancreatitis, mainly by alcohol as well as gallstones. So, to discuss about the surgical events, mainly pancreatic duodenectomy as well as a distal pancreatectomy, which will be predisposing to around 50 to 20% of the population, and this kind of patients will be landing with pancreatic fistula to the at rate of complications. And there is one entity what is called as disconnected pancreatic duct syndrome. We should not forget, once the pancreatic duct, if it is completely gets disrupted, and the distal portion of the pancreatic gland gets disrupted, so there will be secretions will be pouring out in a discontinuous manner. At that point of time, the patient will be going for multiple complications. That's a very difficult scenario to tackle. And regarding this epidemiology, around 5 to 20% of the population may, because of your operating intervention or pancreatic resection. And for example, in the patient who is having evidence of acute pancreatitis, the patient may land up with pancreatic fluid collection. Around 40% of the population may develop, and in that condition, the patient may land up with pancreatic fistula. Around 5 to 10% of the population rarely may develop this kind of event. And once a patient is going to land up with evidence of wall of pancreatic necrosis, that might be predisposing to disconnected pancreatic duct syndrome, around 30 to 40% of the population. And what is the event which is predisposing, whether the ductal disruption or the wall of pancreatic necrosis itself will be predisposing, is still a question we should get addressed. To talk about this pathophysiology, your pancreatic duct, if it is going to be disrupted, or if it is, there are multiple classifications. One is anterior pancreatic, if it is going to communicate to a pectoral cavity, or posterior pancreatic, or side fistula, or end fistula. End fistula mainly because of your pancreatic ductal disruption, or high volume or low volume fistula. If the fistula's output, if it is going to be more than 200 ml per day in a period of 24 hours, or if the fistula's output, if it is going to be less than 200 ml per day, and there is one more criteria, what is called as post-operative pancreatic fistula. After day 3, if the pancreatic amylase is still going to be 3 times more than the upper limits of normal, that might be considered as a post-operative pancreatic fistula based upon your presentation. And clinical features, in which area, which site is predominantly get involved, we need to see. And the site of leak, the size of the leak is very characteristic to determine, and the amount of glandular involvement is very characteristic methodology group for the clinical presentation. And pancreatic ascites, as you all know, low side high protein ascites, and the pancreatic amylase value will be in the higher side. Apart from the pleural effusion, the pleural fluid amylase, there are certain case reports that to go even up to 50,000. So, and apart from that, various other presentation. But a percutaneous fistula, if the patient is having tends to have a percutaneous fistula, the patient may have evidence of dehydration because of continuous fluid leak and metabolic acidosis, bicarbonate leak, that will be predisposing to further complications, weight loss, along with fistulizing site, local site infections, and septicemia to get progress. And this is what the basic manifestations has got to be discussed. Moderate pancreatitis is nothing but once a patient tends to have evidence of acute pancreatitis at that kind of time, if the symptoms is still persisting over a period of time, if the clinical response is not there, and if the patient pancreatic inflammation is still happening, amylase is still in the higher stage, even after the acute event, there's nothing but your small unit of pancreatitis is going to take on. Apart from diagnosis, basically by clinical assessment and your imaging techniques, what are the various imaging, your CT, MRI, EUS and ERCP can be here in your diagnostic of various things. Apart from your basic evaluation will be your CT, MRCP. We need to see MRCP not only and ERCP not only to diagnose, also for the therapeutic purpose to place a stent in case it is needed. Apart from fistulogram, in case if you want to identify the site of internal opening of fistula, which is communicating through external opening, in order to aid that we can use a fistulogram. And this is not the case. If you're going to see, if this MRCP, the pancreatic duct which is getting disrupted, and there is leak of contrast in the chain, and in this area, we can able to identify the MRCP as well as ERCP. In ERCP, we can able to identify the prominent contrast leak in the chain of pancreas, and there is a contrast duct disruption in this image you can able to identify, and moreover in this kind of picture you can able to see more tail disruption changes which is happening with prominent MPD in your chain of pancreas. So this is not about the pancreatic fistula initial presentation. On what is the management? Regarding management protocol, always conservative. Around 60 to 70% of the population will respond to conservative therapy, and mainly we need to target the pancreatic secretions as to come out in order to improve the nutrition process. So correct the electrolyte disturbances, significant loss of sodium, bicarb, all of those things will be there. We need to correct them, and total pancreatic nutrition not supposed to go for a longer duration of time. That is for septicemia. Enteral feeding is always preferred, and in case if you are planning for enteral feed, use of NJ tube is one of the best modality to consider. Apart from definitive management, around 70 to 80% will be closed spontaneously. So we need to wait, and once a patient clinical symptoms responding, we need to wait and watch. Did by oral is the initial phase of management to be considered. Regarding the pharmacological therapy, if the patients are still worsening of symptoms, there are multiple molecules being tried. Among the there are some molecules being tried. What is the role of upgrade? When you are going to give at a rate of 50 to 200 mics for a duration of around 4 to 6 weeks of therapy, and if you are going to inject around 4 to 6 hours daily, that might be having evidence of inhibition of your somatostatin analog, will be having evidence of inhibition of your acceptance secretion which is coming out from the pancreas. Apart from that, but doesn't show any significant effect in your closure rate, and it reduces output as well as it improves your fistula control. And another line of therapy of fibrin glue can be considered, in which the glue, synovial glue can be injected. Nowadays, new innovations like a coil placement to the pancreas fistula also being tried. And endoscopic therapy is very important. Once the patient not responding to medical management, you can place transpapillary or transmural. This is what is called as transpapillary stenting, and transpapillary either to the minor or major pancreatic duct. In order to relieve the pancreatic pressure, we need to place a stent, and this is a basic, more time to show this video. And in this, what we are going to say, once a pancreatic sphincterotomy, if you are planning to do, that might be having evidence to reduce the size of any stone which is going to come out, or reduce the size of inflammation. All those things you're going to take on. And operative management. Operative management, once a patient fails, then we can go for operative management, either your lateral pancreatic or genostomy or distal pancreatectomy if the patient is having any injurious lesions is happening in the body or pain. And disconnected duct syndrome, always we can manage supportive in the initial phase. And 3 trials, one is tail, neck and distal. So tail duct disruption, we need to plan for distal pancreatectomy. Neck, we can place a Rowan general loop anastomosis we can plan, and apart from that, for your pseudocyst, either you can plan for your transpapillary or transmural, and mainly we need to look for the size of the pseudocyst cavity, and if the pseudocyst size, if it is going to be less than 3 pancreatic fluid collection, then we can go for transpapillary drainage, and transmural, if it is going to be more than 6, at that point we can plan for transpapillary through placing through communicating a lumen, creating a lumen between the cystic cavity as well as your gastroduodenal lumen. Apart from that, regarding other interventions, we have debridement of pancreatic necrosis, operating trauma, resection, all those things you can go for, depends upon the area of presentation. We need to manage conservatively, if not works out, then we need to plan the patient for surgical intervention. And to talk something about post-operative pancreatic fistula is a very common scenario, around 10 to 20% of the population may land up with this. So, Once the patient fluid volume is changed to the IR side, and these are all the various criteria to be taken into account. And very important post-operative pancreatic fistula, octreotide, vascular along with the hydrocortisone being used in the initial phase, and we need to look into the consideration to create this, to tackle this kind of presentation. Before concluding, pancreatic fistula is a complex scenario. Identification of the fistula and proper placement of the stent refer promptly to the proper center. That's the most important thing to tackle this. Thank you very much for being here.
Thank you, sir, for sharing your extensive knowledge with us. We invite our esteemed chairpersons and fine audience for any questions or queries you'd like to share.
Regarding the post-ERCP, the combination of isosulfide dinitrate and the diclofenac sodium that reduces the incidence of the post-ERCP better than when the diclofenac sodium alone is used. What is your experience?
We don't use the combination, we use only an diclofenac interface is the positive allowing the fluid addition. Studies have shown isosulfide dinitrate is efficacious in there. There is contraindication to using diclofenac. There is no one-to-one comparison study. Very small studies are there, but definitely there is a contraindication to use the
Risk factor for post-ERCP, what the age and sex is having nothing to do with what is the cause for this risk factor for post-ERCP, age and sex? Can you give an explanation? Why female sex, age less than 50?
So they don't drink alcohol.
So now so maybe the age, probably the younger age, the normal CBD diameter, normal CBD, narrow CBD.
They are difficulty in cannulation, probably. If it is a bilirubin is high, wide CBD, usually because the CBD diameter is between 6, so easy to cannulate. That may be the only reason.
Rajesh, regarding suppose to be very particular time.
Suppose 20 minutes before the procedure is preferable, rather than during or after that.
Dr. Junaid Khan, what is the use of doing a genetic analysis? We cannot do any treatment, and you're here. And if we find a genetic abnormality and then label them as a genetic disorders, if they develop any complications later on, insurance company will object to it, and it will put pressure on patient themselves like whether their children will develop disease. Should we do it or should we not do it?
Right, also the purpose of doing genetic study is to prevent the future interventions. For example, as a theoretical purpose, we try doing the intervention. So to prevent the further workup and further procedure on that particular patient. So because we think that we don't know the etiology, but here the genetic polymorphism is there. So one, American society says that if you are getting this gene mutation, you will be preventing further etiological workup, further intervention to the patient, which may be not required. Only when complication comes, you can do it. And regarding insurance, I don't know whether they cover it under insurance actually, because we get sent, patient will go there and they will cover it.
Disorders means
no, that is because genetic disorder they will come as a molecular thing, they will do the test and that is panel level. So it doesn't genetic testing thing what doesn't come this. New book is doing it like
That's all.
I think it's more of a pressure from the patient side regarding the cause of pancreatitis rather than for the cause of the disease itself or the necessary intervention.
And now the gene splicing thing also is coming. Where they say in the future holds for gene splicing where they can manipulate that gene and to prevent as a treatment we can use it in the future.
Rajesh, you told the risk factor for PEP is pancreatic syndrome. And you have also told that for pancreatic annihilation, you do a pancreatic sepsis. Second point is,
and you are going to put in a pancreatic stent, will you do a pancreatic sphincterotomy prior to putting the stent into the pancreas?
I'm not doing pancreatic sphincterotomy.
No, pancreatic.
Trans sphincterotomy, that's septostomy. You are cutting the common septum. You are not doing a full pancreatic sphincterotomy.
Okay, fine. If they are
comparing the biliary sphincterotomy, doing a pancreatic sphincterotomy is this. But comparing the multiple cannulations, attempting to cannulating for more than 10 minutes, instead of that, if you are doing early transpancreatic sphincterotomy, that's better. That is better.
So pancreatic sphincterotomy.
I'm not saying go straight away doing a pancreatic sphincterotomy. Instead of doing,
it is sphincterotomy only. It is pancreatic. You are cutting the pancreatic sphincter in the direction of the bile duct. So it's called septotomy. So it will make bleeding subsequently bleeding.
No, it is contraindicating. See, the point is the risk factor is you are cutting the pancreatic sphincter is a risk factor for PED. If you are going to do a septostomy also, you are going to cut the pancreatic sphincter. Yes or no?
Yes.
So
But that is why he's draining it with a stent. He actually it's a temporary blockage of pancreatic drainage which is causing it. So if he does that, he's always putting a pancreatic stent also.
The next question is, if you are not doing a pancreatic septostomy or something, but you are doing a double duct cannulation is happening, you are going to put a PD stent. Will you do a pancreatic sphincterotomy?
No.
So last, I think 2 weeks back, Dr. Nagesh Reddy talked about pancreatic, the role of guide wire in pancreatitis. And he said most of the time the guide wire enters the side duct and causes perforation or injury which causes pancreatitis. So, and if you have a longer wire inside the pancreatic duct, it will cause longer wire more. If the wire goes to the tape, the chances of pancreatitis more. So what he said is, if you use angled wire, the chances of that wire getting into the side duct and impacting is less. So it will go in the main duct. And another thing, if you have a wires like this jack wire, which is in 2 colors. So as soon as you cross 10 centimeter, another yellow color will appear. Unlike terima wire, even if you put 50 centimeter, endoscopists won't recognize it. It's the technician sometimes they will push too much wire and cause damage. So these are the angled wires, small wires, and the distance marked wires. The Valibus also has a distance marked, but it is more appreciable in Boston Scientific where the color changes. In Wilson book it is marked 2 circle 3. Unless we see carefully, you won't be able to appreciate it.
Dr. Rajesh, very good. Here, answer. Very good and powerful talk. And I want one simple explanation. During balloon sphincteroplasty, induced PEP, and you have any special precaution to be taken, or what level you will divide for larger stone for smaller 0.5 or 0.6?
Depending upon the stone size and the lower CBD diameter. If it's CBD diameter, there is a, for example, if it's a 12 millimeter, I can say it up to 13 or 14 or more.
There is a large balloon, sphincteroplasty balloon. They are, I think, only 12 millimeter. What we are using is a CRE balloon, which is meant for dilatation strictures in esophagus and other lumen. We normally, if the stone is 12, there is no point in dilating it to 15. If you have a 15 centimeter stone, you have to dilate it to 15 millimeter. The maximum diameter people have got is only 18 millimeter. Beyond, even up to that and beyond, the chance of perforation is very high. Bleeding and perforation. Huh?
Any level beyond which pancreatitis?
Pancreatitis comes if you do a balloon plasty without a sphincterotomy. If you previously
then you do.
Initially people thought if you do a sphincteroplasty, you are not damaging the sphincter. So if you do a ERCP in a child, you remove the stone and then the sphincter will go back to the original function. So there won't be any long-term reflex of duodenal content into the bile duct. There is a concept with which the sphincteroplasty was started. But the initial two cases went wrong. The first case developed severe pancreatitis, died, and then it went out of practice. And subsequently, we have learned that if you do a sphincterotomy and do a sphincteroplasty, then the pancreatitis rates are very, very less.
I think sphincteroplasty is done only in select situations where the stone size is bigger than what you can achieve by doing only a sphincterotomy. But then no sphincteroplasty should be done without a sphincterotomy. That is the golden rule.
Yes.
Golden rule. And if you do a sphincteroplasty without a sphincterotomy, you will end up in trouble.
There are three high risk of pancreatitis. One is sphincteroplasty, ampullectomy, and third is pancreatic duct management. And this comes top of the list.
So how about in case of portal biliopathy? Sphincteroplasty alone in case of portal without sphincterotomy.
Portal biliopathy, I will refer it to you. We can't.
There is any coagulopathy?
Yeah.
Regarding hereditary pancreatitis plan, there was a question. The current ACG guidelines say if you have 2 episodes of idiopathic pancreatitis, go for laparoscopic cholecystectomy. It's a 2024 guidelines. So every surgeon is active doing an APCOL for every idiopathic pancreatitis. That means if you have a hereditary pancreatitis panel telling that it is a homozygous mutation sitting there, you can avoid surgery in a child or an adult. That is one. Second thing is hereditary pancreatitis has got a higher risk of pancreatic malignancy. Generally, in chronic pancreatitis, it's only 1.8% over 10 years. Whereas in hereditary pancreatitis, it can be up to 20 to 30%. That means they need more surveillance for malignancy. These two things we can do a panel, sir. Definitely, we are not going to change the course. At least we can educate.
Point well taken, Dr. Harambe.
Thank you.
I think all patients with recurrent pancreatitis, young age, who don't have a cause, it is worthwhile doing a genetic study because it has favorable points. You can probably educate the patient. Maybe they may need to be educated to know about the high potential malignancies which are required in this patient. And number two, all patients will not be done. All patients will not do genetic study. You need to select and do it because it's not easily done. I think we close the session because time is running. Thank you very much. All speakers, wonderful. Thank you very much. Wonderful session.
It's time to wind up this session. I once again thank the speakers and chairperson for illuminating us with their fine knowledge.
Now let's start the official inaugural session now. And I would like to call the respected dignitaries onto the dais. Dr. Padmashri, Dr. K.R.P. Paliswamy sir, Dr. Prem Kumar sir, Dr. Brahmanayam sir, Dr. Jayanti ma'am, Dr. Barnabas Dureyaj sir, Dr. V.G.M. Mohan Prasad sir, Badri Narayanan sir, Dr. Subramaniam, Dr. Parvati Shankar, Dr. Abdul Aziz, and HOD sir. And also Dr. Bhaktavachalan sir. Duty shapes our path, dignity lifts our spirit, and discipline keeps us steady. Duty, dignity, discipline is the official motto of the college, Similarly Medical College and Hospital. And the official emblem of our college is the caduceus, paddy which denotes the tender belly of the little paddy. So we are greatly privileged to have organized this year's midterm conference.
பொறுப்பிலே பிறந்து தென்னம் புகழிலே கிடந்து சங்க திருப்பிலே இருந்து வயலே ஏட்டிலே தவழ்ந்த வேதை நெருப்பிலே வருகின்ற பாவை மருங்கிலே வாழும் தமிழே வந்த தமிழே செந்தமிழே இன்று கண்ணி ஏறி கலக்கும் மின்தமிழே என் தமிழே என்றும் இளமை மாறாத கவிப்புனையும் பைந்தமிழின் தாயாம் நம் தமிழ் தாய் அவளை வாழ்த்த தமிழ் தாய் வாழ்த்த.
guiding force behind this event and a person whose dedication to excellence shines brightly in all he does. Under his guidance, our Department of Medical Gastroenterology, Similarly Medical College, has grown by leaps and bounds. And Sir has also received the Best Doctor Award from Honorable Thiru Ma Subramanian Sir. and he has been instrumental in guiding our department to the greatest heights. With great honor, I invite Dr. Kandasamy sir, alias Kumar sir, Professor and HOD, Department of Medical Gastroenterology, Tirunelveli Medical College, to deliver the welcome address.
Respected dignitaries and the dais, and also my dear colleagues, my friends, my students, I extend a warm welcome to this reputed midterm ISG conference being conducted in Uttar. And good evening to everybody. It gives me a great pleasure to speak to you today, to welcome you the most cordial at the commencement of 2024 midterm ISG conference of Indian Society of Gastroenterology, Tamil Nadu chapter here in Uttar. This event is a culmination of an enormous collective effort undertaken by the Department of Medical Gastroenterology, Tirunelveli Medical College, and under the aegis of TNISG. Before we kickstart today's program, I, Dr. Kandasamy alias Kumar, the Professor and HOD of Medical Gastroenterology, Tirunelveli Medical College, would like to express my appreciation to the local committee and the TNISG office bearers for their enthusiasm and assistance to make this event a great success. I would also like to express my wholehearted thanks to Dr. Revati, our beloved Dean, Tirunelveli Medical College, for their constant support till date to conduct this conference in its glory. To talk briefly regarding our institution, the government of Tamil Nadu established the Tirunelveli Medical College in 1965 with the agreement of the University of Madras. The college is affiliated to the Madurai Kamaraj University and consequent to its inception in 1967 till the newly formed Tamil Nadu Doctor Medical University, VD Chennai in 1988. The official emblem of this college is codices paddy, that is which has included the donate the that is usually denotes the Tirunelveli. It's a nel is the paddy, and the words duty, dignity, and discipline. The college has reached the PMSSI funding from the Ministry of Health and Family Welfare of the Central Government of India for setting up the super specialty hospital at the campus, and since 2019 it has a functional 7th floor super specialty block. The Department of Medical Gastroenterology, Tirunelveli Medical College, started in the year of 2011 with an aim to provide quality patient care and create qualified gastroenterologists. This first batch of DM Medical Gastroenterology started in 2019. Since the inception of the department, it has provided a state-of-the-art of services and provided training to many aspirants and residents, as our highly specialized unit is equipped with state-of-the-art and facilities including various diagnostic as well as therapeutic endoscopic ultrasound procedures, ERCP, esophageal and anorectal manometry, and transient elastography, to name a few. With an average bed occupancy of over 90% around the year, and we have a record-breaking number of endoscopic procedures going on in the Department of Medical Gastroenterology. The patient-centered research in the various arenas is one of the foremost priorities of the department. With a stringently followed academic curriculum, we have a handful of research studies undertaken and published each year. Our students have shown their presence in various state and national and international conferences with the 2 original research papers presented at the very prestigious Basel conference conducted in Kyoto, Japan in the year of 2024. With a well-equipped liver transplant unit, our department is groomed up to perform its first case of liver transplantation. With a constant improvement as the motto, we drive up the ideology of quality patient care and concrete academic transcendency. And I am proud to welcome the assembled delegates and express my inner happiness, as I know this gathering is going to be a
greater opportunity for us to cultivate a broader understanding of this subject. We have curated the topics in a way it paves an opportunity for engaging discussions and active interrogations. I am very much delighted to host this year's midterm conference here in Kutrala, which is known for its lush greenery and mesmerizing waterfalls. No wonder it is called as the spa of the South Tamil Nadu. I hope you all will have a memorable time here with us in Kutrala. I am looking forward to an enlightening and purposeful deliberations and discussions in the program. I welcome you for once again and hope it will be a grand success with all your cooperation. Thank you very much for giving me this opportunity.
Thank you, sir, for your insightful words. Esteemed guests, it is my honor to introduce you to a distinguished figure in the field of medical science. Dr. Shri K.R. Palanisamy, a Padma Shri awardee, is a renowned expert in the gastroenterology. We're truly fortunate to have him here today. Please join me in welcoming Dr. Shri K.R. Palanisamy, sir, to address the gathering.
Dignitaries of the dais and friends, I would like to thank Dr. Palanisamy and his team for organizing this excellent conference on Kutrala. And you are aware that the scientific attendance are well planned, and you will be enjoying from this afternoon. And you will tomorrow also the lot of topics that we find. Most importantly, apart from the usual topics in the community gastroenterology, this is a session on community gastroenterology. And this I would like to mention that we did this midterm meeting, couple of meetings, along with the scientific session to the doctors. We have had the public awareness program for the public of that area, not for our session. Then we went on the last one was the Kubo one. And after that, I think probably future programs we should try to incorporate the public awareness is most important. Such meetings definitely help the doctors and should help the public also. That I think I would like to again congratulate and wish the conference a great success.
Heartfelt thanks for your excellent words, sir. We are honored to have with us Dr. K. Prem Kumar, a highly accomplished medical professional who currently serves as a director and professor at the Institute of Medical Gastroenterology, Madras Medical College, and the Rajiv Gandhi Government General Hospital in Chennai, and currently are president of the Indian Society of Gastroenterology, Tamil Nadu chapter. Please join me in welcoming Dr. K. Palani Kumar, sir, whose contributions to the medical field continue to inspire us to share a few words.
Respected patron, teachers, dignitaries on the dais, fellows of gastroenterology and students. As president, I'm very proud to say that our society has been in the forefront, and for the last more than 2 decades, we have been imparting knowledge regarding gastroenterology on a regular basis by conducting meetings, midterm meeting and then annual meeting at various venues and places. Just by dissipating GE knowledge to all not only the gastroenterologists but also the physicians and the surgeons who work in the medical field. As I told, and apart from that, we have been conducting meetings for the general public to increase the awareness regarding the health issues. I'm sure that this will continue and this will go on. The next generation definitely take up. During the last annual meeting, when we are looking for revenue, who will be conducting the meeting, I'm happy that Dr. Palanisamy had readily agreed to host this meeting, and I'm sure that he has planned out, he and his team has planned out not only the venue, which is really good, and the academic schedule. Initially we thought it was a lot of topics that included. I'm sure that the timing, everything went on well, and so far has gone. I'm sure that the rest of the team also go on well. I congratulate Dr. Palanisamy Kumar and his team for this excellent organization, and thank you very much.
Now, it's my honor to invite a highly respected gastroenterologist, Dr. T. Brahmanayam sir, the current secretary of ISG Tamil Nadu chapter, and and affiliated with our last bill. Please join me in welcoming Dr. B. Pramanayagan sir to share his insight with us.
Respected senior faculty on the dais, off the dais, dear friends, postgraduates, I think it's a great honor for me to be here standing in front of you as the Secretary of ISG TNC. It's been a big responsibility as well as a good opportunity for me to take it forward. And I'm really happy that this time around I was fortunate enough to work with Professor Kandaswamy and his team in organizing this midterm ISG meet. Initially I was a little wary that given that Kuttalam is a venue where we have chosen, I was wondering how many people will actually stay back in the hall. But I think we had almost 90% of all the people who have come here stay back in the hall for the whole evening and the afternoon as well as the evening. That tells so much about the content of the program as well as the speakers who are coming here to deliver the lecture. I really thank you and congratulate you for organizing this in such a wonderful way and for your great hospitality also. And hope the same thing continues tomorrow as well and we come back here for more deliberations in the future as well. Thank you so much. I welcome you all again.
Thank you, sir. Now, to address this grand gathering, we welcome our core member of ISG, the striking experience of knowledge and big leader. Being a beacon of excellence, she has more than 200 national and international publications and received several awards from prestigious global organizations. Without further delay, I would like to invite Dr. B. Jayanti ma'am, Senior Consultant Director and Housing Project Reliance Global Institute Chennai, after the state to raise this gathering.
Good evening to seniors on the dais, colleagues and friends. This is the first time I'm giving a talk like this. This is the first time I'm speaking in an inauguration session. It has been a great honor. Actually, I was planning not to come, but I think Dr. Kandaswamy persisted and he said, senior sectogenarians, around about 17, should be here to encourage the youngsters. So we are here to be with you all. And I've been following Dr. Kandaswamy in the TNISG forum, and we see excellent endoscopic procedures being done by the center. I'm really proud, because we always keep thinking as Chennai as one of the leading centers, but centers like the all are doing exceedingly well. And the topics that you have chosen are excellent, and I'm sure the session has gone on really well. And best wishes to you and to your team, and we want more publications from the center, so that's what we're looking for. All the best.
Thank you so much, ma'am. I request Dr. Varma Zoyrat sir to facilitate the gathering.
Good evening to all my senior colleagues and junior colleagues. It's a great privilege for me to attend this midterm conference in Kuttalam and really appreciate the good work done by Dr. Kandaswamy and his team in establishing this midday conference. And again, there's a repetition that all the topics chosen were excellent. All the speakers, they gave a good talk, and really I have become more wiser after attending this conference. Before that, my knowledge was very poor, and after attending this conference, I have become more wiser. And I am taking privilege to say that Dr. Kandaswamy was my best student when I was the head of Department of Gastroenterology in Madras Medical College. And really, I feel very happy. The work he has done, wonderful work he is doing in Tirunelveli Medical College. And again, he will be in future also he will be doing, and really I feel very happy and very proud. And again, I am very proud to say that I am a student of Tirunelveli Medical College, very second batch of Tirunelveli Medical College. And I wish Dr. Kandaswamy and his team a good future, and again they will do good, wonderful work in future also. I wish them good luck. Thank you.
Thank you so much, sir. I request Dr. Madhinarayan sir to facilitate the gathering.
Dear friends, my teachers, let me take this opportunity to congratulate each and everyone who has toiled to make this wonderful midterm conference, a great success. The entire topics which were discussed so far, extraordinarily good, and it was a fantastic and fabulous experience. Congratulations to Kandasamy, Shafiq and his team for doing this wonderful arrangements. Thank you.
Thank you so much, sir. I request Dr. Maktarchal, sir, to facilitate the event.
It's a great day. First, I congratulate Kandasamy for having put Tirunelveli in the gastroenterology map of the entire world, not India, but the entire world. He is doing so many great things in Tirunelveli. Some 30-40 years back, when I was allotted to Tirunelveli Medical College as a student, I felt very sorry and I wanted to do studies at MMC. Now I realize, after so many advances and so many great things happening in Tirunelveli, my thinking was not correct at that time. And thanks for all the organizers, in particular Dr. Prabhanayam, Dr. Payne. We have seen many pillars in gastroenterology, but they are the basements in the gastroenterology. Without the basement, there will not be pillars. They do great things, begin to see, without much these meetings will happen. Thanks, sir. And Dr. Barnabas sir, being the teacher, a good friend, and Dr. K.R.P. sir seems to be so cute and dressed. The double helix structure may change, but the K.R.P. sir will never change. Even the DNA can change, but you will never change. And thanks sir, you have seen many sons, daughters, and now you have seen granddaughters and grandsons in gastroenterology. And hope you will see more generations to come. And Jayanti madam, I was a student of madam. And normally we used to have some sessions at CMC Vellore at that time. For 15 days we will go there, and at that time madam was there. And I was allowed to present a case. And she was the toughest examiner at that time. And after getting trained from her, I became very knowledgeable, and the exam was very easy because of madam's guidance. In those 15 days I can never forget it. Badri sir was my mentor. And I was doing MD General Medicine, and I went to his clinic and asked sir, you have a book in the PG exam or the DM prepare பண்ணலாம்னு இருக்கேன். போய் அதை அப்படி ப்ரிப்பேர் பண்ணிலாம் வாங்க முடியாது, நீ போய் படி, எதாவது படி. பிறகு compulsorily I got 2 books from him. And that books, whether I read it or not, that was my stepping stone for entering into the post graduation. And Ajit sir, one small thing, some 20, I came here around 2000 after finishing my DM, that is almost 24 years gone. He came and asked me, Mutharajan, ஏதாவது ஐபிஎஸ்க்கு ஏதாவது புதுசாக ட்ரீட்மெண்ட் வந்துருக்காங்க. ஐபிஎஸ்க்கும் ஒன்றும் வரல இது வரைக்கும், அவரும் அதே மாதிரியும் மாறலை, ஐபிஎஸும் மாறலை, அஜித் சாரும் மாறலை. He also looks very cheerful and energetic. And Dr. Subramaniam, always a good colleague, always cheerful, always smiling, in spite of all his heavy schedule. And anyway, it's a good show, great things we have learned, and it's a, we cannot say it's a small conference, it's a big conference done in a very clear and gentle way. Thanks, Kandasamy, for many more accolades to achieve, and all the best, and let God be with you. Thank you.
Thank you so much, sir. I now request Dr. Subramanian, sir, who is the IFA President of Tirunelveli, to address again.
Good evening, everyone. Respected senior faculties, state president, office bearers of Tamil Nadu chapter IGS, and also my teachers. பக்தர்சன் சொன்ன மாதிரி சார் தான் எனக்கு ஹவுசேஜனில் டீச்சிங் பண்ணாங்க. அப்புறம் பர்னபாஸ் சார் வாஸ் மை கேஸ்ட்ரோ டீச்சர் when I was doing MD medicine in Chennai. So thank you, sir. I'm really thankful to be part of this innovative program, midterm IGS conference. So இப்போ வந்து the new inventionல வந்து lot of interventions are happening. So I'm really glad that gastro is going neck and neck with the cardiology. So even taking away some of the surgical gastro roles, நோய் முதல் நாடி நோய் தணிக்க வாய் நாடி தணிக்க செயல். ஸோ வந்து நம்ம நோயை கண்டுபிடிக்கிறதுல ரொம்ப இம்பார்ட்டண்ட்டாக இருக்கிறோம். ஸோ அதே மாதிரி seeing the ERCP and other procedures, so lot of innovations and invention happening. We also feel part of this IMA generally, and also as the APA secretary, I'm really glad to be part of this function. Thank you everyone. I wish this function all the best. Thank you.
Thank you so much, sir. I now request Dr. Abdul Aziz, sir, IMA member, to travel to address the gathering.
Respected dignitaries on the days and of the days, good evening to everybody. So, I am in Kuttalam for the past 40 years after finishing pediatrics. I am here and I was in government service for 22 years. Then I am having a full-time nursing home. So, I want to congratulate Dr. Kumar sir and Dr. Shafiq. Shafiq is my son-in-law's own brother. My son-in-law is a urologist in Tirunelveli College, his own brother. I know how much effort they have taken because Tirunelveli Alva இனிக்குங்கிறது நம்ம சொன்னாதான் தெரியும். பட் நான் கண்கூட அவங்களுடைய இந்த ஒரு 10-11 மாதம் இருக்குன்னு நினைக்கிறேன். அவங்க இத்தனை தடவை வந்து என்னென்னலாம் கன்சல்ட் பண்ணி உங்களோட ஃபெசிலிட்டிஸ்லாம் எப்படி இருக்கும் எது இருக்குன்னு சொல்லி ரொம்ப ஒரு ஸ்ட்ரெயின் எடுத்துக்கிட்டாங்க. அந்த ஸ்ட்ரெயின் தான் நீங்கள் பார்க்கக்கூடிய, ஏன்னா இது ஒரு பெரிய இடம் இல்லை, ஒரு சின்ன ஊர் தான். அஃப்கோர்ஸ் நீங்கள் நேச்சுரலாக நல்லா இருக்கும். நீங்கள் அன்ஃபார்ச்சுனேட்லி போன வரணும்லாம் நல்லா குழுன்னு இருந்தது. அது எப்போ மழை வரும் எப்போ மழை வராது சொல்ல முடியாது. ஸோ அதனால் வந்து I think you all enjoyed the thing and you can enjoy still, not only academic, and you can go to the falls and there are some hill areas in Kerala and the other areas, and Dr. Shafiq and they have taken much time, each and everything, food and everything, because I am also a very good organizer. We recently organized a 1200 IAP conference. I know whether it is a small and thing to organize a thing very difficult. And little word about Bhadranath sir, actually I was going to him for IPS. One day he put I tried to put in my this endoscope. Then I was suffering from a lot of the 2 or 3 years. I went to Chennai, I went to Trivandrum. Then one day I asked Dr. came, is there any treatment? He told it is not a irritable bowel syndrome, it is a irritable brain syndrome. He told that about the brain and gut axis. On that day I have completely relief of the IBS. So IBS is for a patient it may be difficult. Suppose if he is actually he has changed my life because I was going here and that problem, but I have not done after him, and my son-in-law also I was doing to him. So you are having a very good, and gastroenterologist I used to tell from mouth to ears, lot of problems are there. They are very good hopes, and even though I am a pediatrician, I see all the cases. My son is AMD, so I wish you a good luck. And any time you can come to Kottaram to our place. We are ready to give you good hospitality. The Tirunelveli district is good for hospitality. Thank you very much for inviting. On behalf of Kottaram IMA, on behalf of IMA TNC, I was talking to the state president and secretary. They asked me to convey their regards and wishes to this conference. Thank you very much.
Thank you so much for your entertaining speech, sir.
Now let us have the felicitation. I would like to call upon our HOD sir, Kandasamy sir, to felicitate Padma Shri Dr. K.R.B. sir. Dr. Dr. Badrinaran, sir. Dr. Subramanian, sir. Dr. Abdul Aziz, sir. Dr. Bhakta Machine, sir. I would like to call upon our assistant professor, sir, Dr. Shakti, sir, to deliver the vote of thanks.
It's my honor and privilege to deliver the vote of thanks to this august audience in the association of Victor, Conference of the Indian Society of Gastroenterology chapter. First and foremost, I extend our sincere gratitude to the ISG Tamil Nadu chapter for giving us this wonderful opportunity to organize this function in a grand manner. And I would like to express my thanks to our Chief Guest, President already, Dr. C. Revati Bolan, Dean DMC, for honoring us with the presence and support. A special note of appreciation goes to our beloved Professor Dr. Kandasamy alias Kumar, Professor Ashodi, DMC students, for his sincere effort in organizing the event. At the outset, I would like to thank the senior most gastroenterologist, Padma Shri Dr. K. Panirsamy, our patron, and our President of ISG, Dr. Prem sir, and Secretary Dr. Karunayam sir, and also sincere thanks to senior most gastroenterologist Dr. Jayanti madam, Dr. Padma Adriva sir, and Dr. Badrinaran sir, and Dr. Bhakta sir. Without them, this discussion would have been not better. Additionally, I would like to thank the other important persons like IMA President Dr. Subramaniam and also IMA Kutrala Dr. Abdul Aziz for this occasion. And special thanks to our sponsors, all the sponsors, Torrent, Sunpharma, Looping, About India, Cipla, Foods India, NATCO, Tablets India, Lavina, Microlabs, Zydus Pharma, and also hospitals, Kaveri Hospitals, Tirunelveli, Shifa Hospitals, Tirunelveli, and also Olympus, Fuji, Endocare, Boston, everyone. Their all support is very crucial in ensuring the success of this conference. And also I extend my gratitude to the faculties and delegates of this conference, and also special thanks to our dear postgraduates and also MBBS students who have come all the way from Tirunelveli Medical College to support, and their enthusiastic effort and assistance make this event a great success. Thanks for all of you for being part of this memorable session. Thank you, and all. Thank you.
So we are coming to the end of our inaugural ceremony. Let us all rise up for the national anthem.
privileged to have such exceptional figures as chairperson guiding this important session. With great honor, we welcome Dr. V. Jayanti ma'am, Dr. G. Badrinarayan sir, Dr. R. Ramasubramanian R. sir to the stage.
And at the end of this session, we have the preliminaries for the quiz competition at the first floor boardroom after this session.
For this session, we are honored to welcome a distinguished physician with an impressive 30 years of experience, including 20 years dedicated to hepatology and 14 years specializing in liver transplantation. His extensive knowledge and research interests in non-invasive liver fibrosis testing and acute on liver chronic failure management position him as a leading authority in the field. We are thrilled to have Dr. Ian Mulgrew sir with us today to share his insights and expertise about master reading in this session.
We have an important session today on metabolic dysfunction associated steatotic disease. The nomenclature has changed, the classification has changed, and lots of changes have taken place, and there are newer drugs now on the horizon for management of these patients. And to speak on this, we have Dr. Mulgrew, Senior Consultant Hepatologist at Apollo Hospitals, Chennai. Dr. Mulgrew, please. Can we have the audience please be seated? We will wait for 2 minutes more.
Thank you, Dr. Jayanti. Yeah, it is an important topic. Interesting thing I noticed, most of the time fatty liver talk is held before the dinner. And whatever we talk here, we're going to forget when we see the food and the cocktail. But still, I think we should know risks of having fatty liver, which most of us in the room may have. And like Dr. Jayanti said, there's a lot of changes happening. It was like hepatitis C was 10 years back. Suddenly there was interest in hepatitis C, a lot of drugs came. And every time you go to a meeting, you keep hearing new things. One drug which was useful 1 year back was abandoned. The same thing is happening with NASH and NASH treatment. So whatever we talk here today may not be relevant in a year's time, but we need to keep up to date so that we can keep up to date and help our patients about this. So MSLD is a very huge topic. We can have a 2-day symposium on it. So I'm going to stick to certain important points that I think we should all know as practitioners. Obviously, you need to know the new definitions, natural history, impact on health in our patients. We need to assess the risk in each patient who have fatty liver. Traditionally, we used to do liver biopsy, but now that is not an option in day-to-day practice. Even in research, we are moving away from biopsy and going into NIT or non-invasive testing, so that's going to be the future. And again, a huge array of tests are coming through. Some of them may be useful, some of them may not. So we look at that. And a brief approach to management. We still rely a lot on lifestyle changes as part of the management of MASLD, which is a difficult part because it's not in our hands. It's in the patient's hands. And of course, pharmacotherapy is emerging, and we'll talk a little bit about it. So this is a new definition. This is a new definition of fatty liver disease. It is called steatotic liver disease, agreed by almost all the societies in the world, including the INASL. And what we are concerned today is what we used to call NAFLD, metabolic dysfunction associated steatotic liver disease. The word metabolic was thought to be important because this disease is related to metabolic dysfunction or metabolic health. So we have to include that as part of the definition. And it broadens the outlook about the disease rather than focusing only on non-alcoholic, we're looking at the metabolic profile. Interestingly, you can have metabolic disease and drink alcohol. Earlier we had no way of classifying them, so they brought this term, ALD, where you have both metabolic dysfunction and alcohol use. And they quantify the amount of alcohol. So if it is between 30 and 60 grams per day, we call it met ALD. If it is below 30 grams per day, we call it metabolic. If it is above 60, we call it alcohol. So we need some definition because there will always be gray areas.
But generally the rule is any alcohol is bad for anyone, especially if you have metabolic dysfunction. Also interestingly, they listed the metabolic syndrome criteria and have simplified it. So I don't want to go through in each detail, but you can look it up. Basically it includes weight, glucose, blood pressure, triglyceride, HDL. And if you have any one metabolic parameter, you qualify as having metabolic dysfunction. Earlier we need 3 to call it metabolic syndrome. So this may change because there is some argument saying that it is too broad and literally everybody in the world may have metabolic dysfunction. But as of now, this is the recommendation and we are just following this. So to start, you have a diet which is high in calories, what is called obesity diet. You have weight gain and physical inactivity. This is a typical modern individual. In obesity, children also fall into this trap. This is the kind of person we see. And the modern lifestyle is facilitating this more and more. So this will increase visceral adiposity. You will start getting resistance to insulin, which is an essential part of digesting glucose that we eat. Then what happens is all the glucose then starts forming free fatty acids. You may get diabetes, everything goes to the liver, triglycerides start getting accumulated. Sorry, chair is coming in the way, but there are a lot of cofactors that influence how the fatty liver affects a patient. So it is not uniform, every patient will behave differently, there is a lot of heterogeneity. And the reason for that is there are genetic factors at play. There may be gut microbiota which play a role, but we still don't know how they play a role. And obviously ongoing lifestyle. Your lifestyle may get worse or better, that is also going to have an influence. And taking alcohol. So all this will stress the liver that is already having fat due to your lifestyle. And then in some patients, there will be inflammation, activation, basically inflammation. Then various changes like IR stress, oxidative stress, which causes an inflammation to set up in the liver. This is very similar to alcoholic steatohepatitis, except there it is directly caused by alcohol. Here it is caused by metabolic stress, and sometimes by both. So once the inflammation sets in, you immediately get mucosal cell activation, which is like a repair job, but it repairs the inflammation by fibrosis. When this carries on, you get cirrhosis. So to switch it off, you have to switch off the metabolic stress. You have to switch off other stressors. Maybe you have to manipulate that microbiota. We don't know how to do that. Alcohol obviously has to come. Lifestyle. So these are the ways you manage this condition in several terms. What I want to, all of you may know, but in the public and even amongst non-specialist doctors, there is a belief that fatty liver is common, everybody has it, so what's a big deal? Don't worry about it. But it's important to know that a good proportion of them progress to cirrhosis and cancer. Probably around 25% of patients with fatty liver may go on to develop steatohepatitis. A proportion will go on to develop varying degrees of fibrosis and end up in cirrhosis. So roughly 5 to 10% of patients with MSLE may end up with cirrhosis over a 20-year period. That's a significant number. Especially if you take that 1/3 of the population may have fatty liver, the numbers will be huge. Maybe 2% of population may have fatty liver related fibrosis or cirrhosis. So we have to take it seriously, and we have to make the patients take it seriously. This graph is important. This was from a recent review in Lancet, October 2024. Timeline to cirrhosis depending on the stage of fibrosis when you first diagnose a patient. Because the treatment approach is key based on this findings. If they have only F0 or F1, they'll have a lot of time, 30-35 years before they get cirrhosis, provided they stay with lifestyle changes. If they have F2, 19 years, F3, only 6 years. So for us it is important to identify those patients who have F2, F3 before they get cirrhosis. Traditionally, we diagnose them after they get cirrhosis. You see an ultrasound with cirrhosis, or they come with cirrhosis complications, and then you realize they have fatty liver.
Now we want to identify them at the early stage of F2, F3 fibrosis, so that we can prevent this progression. We have a 6 to 10 year time period to do that, so we have a lot of time. We all know that fatty liver disease or MSLD is a multi-system disease. But the bulk of the impact of MSLD is in the heart. Most of the deaths are due to cardiovascular disease. Cancers are increased due to MSLD directly or due to the comorbidities like obesity, diabetes. And of course, liver takes a big burden of the disease. So all three are the organs of the liver, but a variety of other changes happen, including OSA, PCOS, diabetes, sarcopenia, CKD, and so on. It's a true multi-system disease. It belongs to all specialties. Every specialty sees fatty liver or MSLD patients. Diabetologists probably see more than we do. Cardiologists may see more than we do. So all of them have a stake in this disease and in improving this condition. Another reason why MSLD is important, especially in the terms of multi-organ dysfunction, is the mortality it may cause. This is a beautiful study published 7-8 years ago. It's a population-based study. They followed a patient for 6 to 8 years and then projected them for 30 years. In a population without fatty liver, average death rate is around 15%. If they just have fatty liver without known cirrhosis or fibrosis or NASH, there is almost a doubling of the mortality. And most of the deaths were due to cardiovascular disease or cancers. So it doesn't necessarily mean fatty liver is causing cardiac disease or cancer, it is associated. So it can even be a mirror to somebody's health. If you have fatty liver, you are not healthy. You may die much more than if you don't have fatty liver. So do something about it. So it's a wonderful example of that. Once you get NASH, the overall death rate increases, but the liver-related death rate also increases. So you have your cardiovascular cancer death and also liver-related death. Naturally, NASH will progress to cirrhosis, liver cancer, and you die. So this is the danger of having fatty liver, which we should all know and explain to our patients. So with this background, you have a patient with MSLD. So what can we do to assess the patient's liver? We focus on the liver since that's what we are doing. Because talking about everything is not possible in ingredients. So we focus on the liver. What are the ways to assess the liver in a OP setting or in current practice? And what are the treatment options currently available? Mostly in India, but we'll talk a little bit about other drugs. Again, important to know the stage of fibrosis every time you treat a patient, because that will determine the outcomes and how much you want to treat the patient, how much you want to follow the patient, how aggressive you will be with your approach. So if they have F0, F1, their kind of mortality is kind of similar to a fatty liver patient over a period of 40 years. But once you start getting F2, F3, F4, there is an increased death rate. The number of patients living are less, and obviously it increases with the increasing level of fibrosis. So you want to start targeting patients in this group, F2, F3, F4, to identify them and pick them up for treatment. So how can we do that? The gold standard is a liver biopsy. So a liver biopsy, I put a slide, but I think I've taken it out. But we don't do liver biopsy routinely with every fatty liver patient. So it's not possible. And like I mentioned, even in research, they are moving away from biopsy, trying to use standardized non-invasive tests which are validated to even assess drug therapy and equivalent to drug therapy. The non-invasive tests are still a bit crude with a lot of error rate, but slowly they're getting more refined. So hopefully in the next few years, there are more coming, there are new tests coming. So hopefully in the next 2, 3 years or 5 years, we'll get to know how to use them in a better way. What is available now, which has been endorsed by the societies like EASL, ASLD, NASL. I'm just going to highlight that. There are a huge number of tests already available, different combinations, AI-driven, computer-driven, so many different combinations are there coming as a score, or with some local validation. But what is broadly recommended is, if you're using blood tests, FIB4, simple test, AST, ALT, age and platelets,
You put a score, you get a score. This is now recommended as a screening test for all patients with fatty liver. So it is kind of mandatory to do this for everyone you see with fatty liver and repeating every year to see whether they are. The primary aim was to expand this to non-gastro liver doctors, particularly endocrine physicians and so on, so that they can do it in their clinic. If FIB4 shows high value, they are more likely to have liver fibrosis, then you consider referring them to a specialist. So you don't have to refer every fatty liver to a specialist, because some of them don't want to. And also the specialists may not, at least in other countries, they don't have time to see them. So you use it as a screening tool to identify the ones who are at risk using simple measures. It's fairly accurate, maybe 75-80% accurate. There is a little more advanced test called the ELF test, which is available in India, but I'm a little bit doubtful about the accuracy of the test that we use in India. It's kind of locally modified, but it is commercially available from labs. So this is looking at 3 markers of fibrosis, and then there's an algorithm, log-driven algorithm, which gives you a score. Hyaluronic acid, propalagen 3, PIINP, and TEMP1. So there's a combination of these 3. In US studies and European studies, they're saying it's fairly accurate. But whatever I've seen, whatever I've used in India, there's a familiarity. They keep changing. Somebody with cirrhosis having normal tests, so it's very erratic, so I'm not really sure whether I should use it here. The way it is being even worse. But this is another test that has been approved. But now we are relying more on imaging to diagnose fibrosis before the stage of cirrhosis or very, very early stage of cirrhosis. The most widely tested in the world with the most literature and most guidelines supported test is the FibroScan, also called transient elastography or VCTE. It is expensive, so not many centers may have it. There is the option of ultrasound-based elastography, which is now called as shear wave elastography, which is also reasonably accurate. But the cutoffs for treatment, the cutoffs for various points in the disease are not well defined like FibroScan. And MRE is considered the best because it examines the whole liver and gives a composite stiffness and fibrosis value. But again, MRE is expensive, it's not something the patient will like to do, not available in many centers, it needs a special software to do it, and some amount of training. FibroScan is being widely promoted around the world because it is done by the hepatologist or gastroenterologist in their own clinic. So it's called a point of care test. The patient comes to you, you counsel them, you do a FibroScan, you see them, everything is there in your own office rather than refer them to a scan, come back, and so on. So it is gaining wider acceptance around the world. Again, in India, the cost is the limiting factor. There are 1 or 2 newer tools coming. Siemens is coming with some artificial intelligence-driven software where they're using the fat concentration with fibrosis elastography and some biochemical parameters and demographics like age, diabetes. They started a nationwide study, we are also enrolling with them, but it's a 5-year study. So after 5 years, we know whether it's useful or not. There is a group of hepatologists in the US called the NASH CRN group. Dr. Arun Sanyal, you may have heard of him, he's a leading researcher in NASH. So he's involved. They are developing a new machine like FibroScan to be used in the office, and they are quite enthusiastic that it may be good. So these are 1 or 2 new things that may come in the next 3 to 5 years. So this is the algorithm that is recommended for anybody who is seeing a patient with fatty liver. First of all, who should be assessed for fatty liver? Should everybody get it? Definitely somebody with diabetes, metabolic disease or obesity or overweight should get it. Remember in India, overweight means 23 DMA and above, which is very tough for most everybody in the room, it will be very clean. Or if you have abnormal AST/ALT or you have fat in the liver on ultrasound, then they need to be analyzed further. So the recommendation, this is from AGA, American Gastroenterology Association. They are asking whomever seeing, physician, dermatologist, whomever seeing, to a FIB4. If FIB4 is low, less than 1.3, then the patient has very low chance of F2 or more fibrosis. And remember I showed you if it's F1 and F0, the longevity is 30-35 years before they get disease. So you still counsel them for general health. You check cardiac, you check diabetes, counsel them for general health, but you don't have to worry too much about the liver at that point. But every year you have to repeat it. If they come under the high value, greater than 2.67, they are very highly likely to have fibrosis. So you refer them for some specialized attention. If they are in between, you can choose to refer them, or you can do a second assessment, which is usually a fibroscan or a health test, and then see what the value is. And they're given some values for the fibroscan. 8 means no fibrosis. 8 to 12 is intermediate. More than 12 means very high chance of cirrhosis. So the fibroscan is a little more accurate than FIB4, and we can combine the two also. So this is what the recommendation is for anybody who sees when we can do this algorithm. Non-specialists can also do this algorithm. But it's important to talk to whomever is seeing fatty liver in a hospital or in the area. And please request them to FIB4. If FIB4 is high, please request them to follow it up. It's a key message. So what we should do is target two groups who are likely to need treatment and close attention. One is what is called as at-risk NASH. This is a new term which is kind of in the last 1 year has been around. It is called at-risk NASH, which means you have some amount of NASH, non-alcoholic steatohepatitis, and early fibrosis. This will only be seen usually in a biopsy, but we are not going to biopsy in all patients. So can we identify this non-invasively in an accurate way? So this is the at-risk NASH. How to identify at-risk NASH? Second group identifies advanced fibrosis because they are likely to get cirrhosis in 5 to 6 years. You have a short time. So you really need to pay attention. Some of them may already be cirrhotic. So these are two groups you need to assess in the clinic. Remember that means no other test is showing cirrhosis. Ultrasound, CT scan, blood tests don't show cirrhosis, but you still want to figure it out. One score which we have started using now because it comes with the fibroscan is called the FAST score, which is supposed to identify at-risk NASH. So you use fibroscan, the CAP value, which is the fat percentage, the liver stiffness value, which is the fibrosis, and the AST, and you get a score. This is only available to fibroscan users. You have to put in your serial number to get an entry, and then to get a software, and then you can use this. So if it is more than 0.67, then that patient has 90% chance of having at-risk NASH. So now they are trying to use this parameter to start drug trials. So instead of getting a biopsy, it will say biopsy proven NASH. So all the drug trials will say biopsy proven NASH, biopsy proven NASH. So can we say NIT proven NASH? So this is where they are going with this. And this seems to be fairly accurate, so we have to wait and see. So one more score which has just come 3-4 months back with the one center validation, but still not yet approved for regular use by the societies. It's called the MASSEF score. Again, this is done by the NASH CRM group in the US, which is a group of hepatologists who are studying NASH in various ways. So they are trying to do only through blood tests without using any scan or fibroscan. So it's called metabolomics advanced steatosis fibrosis score. Again, this is to identify at-risk NASH, which means they have steatohepatitis at least 4 points. This is a biopsy score. This is a biopsy score, so it's equal to that, plus F2 fibrosis. They are using 12 lipid parameters. They are using BMI, AST, ALT. I am not very familiar with it because it's not yet marketed. There's no score that you can go to the computer and do, just one published paper. In the paper, they have shown it is comparative to the FAST score. All that means area under the curve of 0.76, which roughly means 76% accurate. They published in Hepatology in June. So maybe one of these scores will become a standard of care for us. We'll have to wait and see. But if you have fibroscan, you can use the FAST score. The next challenge is to identify F3, F4 fibrosis before you see it on ultrasound. Again, there is no approved score. Currently, I can only talk about fibroscan because there are some values that are already established and given. So if you have a fibroscan score of more than 12, it is considered advanced fibrosis. Advanced fibrosis means F3, F4. Now remember, many of the drugs are contraindicated in F4. So how do you differentiate F3 from F4 is very difficult without a biopsy. But if it is more than 12, it is F3, F4. Maybe if it is 15 or more, we can take it as cirrhosis. Some authors have come with a number of 13.5. So all these are just numbers thrown out. There's no proper correlation. The same group that developed the FAST score is now developing two more scores called Agile 3, Agile 4. Agile 3 is to diagnose F3, Agile 4 is to diagnose F4. Again, this is using fibroscan values. So this is mainly for fibroscan users. It's not fully out in the market, but it should come very soon, that's what I understood. So again, we are trying to define all these parameters which are usually done on biopsy in a fairly accurate way using non-invasive tests. So that's why the confusion. So right now, we can take maybe 12 as something to worry, and 15 means definite cirrhosis. But we know which is the body of studying portal hypertension. In the recent guidelines have mentioned that if somebody has stiffness value of more than 20 and platelets of less than 50, 150, then they are likely to have significant portal hypertension, likely to have varices. So you can treat along those lines. In fact, they are recommending beta blocker for these patients irrespective of variceal size. Normally, we give prophylactic beta blocker for large varices or varices that need treatment. But here, to reduce portal hypertension related complications, there is a new recommendation from about 1 year old. If LSM is more than 25, you can also assume they have significant hypertension. So again, these are just trying to refine non-invasive tests in a better way so that we can use them in day-to-day practice without needing biopsy. So the treatment goals for that MASH will be, you want to completely resolve MASH or steatohepatitis. You want to hopefully resolution of fibrosis, but at least one stage improvement of fibrosis. So if you achieve this, you can improve clinical outcomes, liver-related outcomes, and all-cause mortality. So you can do this with lifestyle drugs, whatever way is possible. So when you come to treatment, the bulk of the treatment will be lifestyle modification at all stages. You can target components of the metabolic syndrome, which may not directly help the liver, but will help the overall longevity. Pharmacotherapy and complications of cirrhosis. So I just talk briefly about each lifestyle change, diet, exercise, weight loss, because it's something we talk to our patients on a daily basis and they keep on noting it here. So is there a scientific way to look at it? There are lots of papers written. I'm just summarizing some guidelines. Basically, if they are overweight, you want a calorie deficit diet. So we shouldn't worry about types of diet, types of food items. Basically, what a calorie deficit. How you achieve it is up to you and up to the patient. They can starve, they can fast, they can eat less per day, they can take 2 meals a day, intermittent fasting, whatever they want to do. Intermittent fasting works very well. I try it all the time. It works very well. So if somebody wants to try this, perfect. So calorie deficit 500 to 1000 kilocalories per day. The Western articles recommend a vegetarian diet because it fits correctly with what we want to do. We want a low carb diet. We want low saturated fat, normal to high protein. So this vegetarian diet gives you that. So we can adapt this to the Indian diet. So this is what most dietitians should aim, and they do it in many hospitals. Many people may know this, but coffee is good for fibrosis. If you drink 3 to 4 cups of coffee, but no milk because it increases fat and no sugar, definitely no sugar. Will reduce fibrosis. There's a debate whether it is a caffeine that's doing it or other chemicals that are found in the coffee seed and plant. There's some debate about it. Probably a bit of both. But if you drink coffee 3-4 times a day, it is good for fibrosis. It actually reverses fibrosis in many patients. As far as exercise is concerned, a key component of lifestyle change may be more important than diet. Minimum 150 minutes per week. 3 to 5 days, minimum 30 minutes per day, moderate intensity, not just casually walking, but has to be brisk exercise. The current recommendation is to do both aerobic and strength training, and it's clearly been shown that this combination helps better than each. And independent of weight loss, it reduces liver fat. Weight loss is the best way to remove liver fat. Even if you achieve 10%, it helps a lot. You can improve the diet and exercise. There are weight loss pills. There are now these exciting anti-obesity drugs, single agonist, dual agonist, triple agonist, enterobariatrics, many of you are doing them, and diabetic surgery. All this will help in weight loss. Just 3% weight loss will reduce steatosis, but 10% weight loss will reduce fibrosis. So it works, definitely it works. So we come to pharmacotherapy. These are the drugs that can be used in India currently. The Respiratory is US FDA approved. It removes obeticholic acid, but it is still available in India. The US has moved on from it. They are not going to pursue that obeticholic acid. So basically, they moved on to other drugs. So I'll quickly go through them. This is an old period study from 2010, which set the ball rolling for drugs for NASH. It improved NASH quite significantly along with pioglitazone, but did not improve fibrosis enough to get FDA approval, and gradually it was given up. But still a good drug. I think a lot of us use it. 800 milligrams a day is still a good drug to use. It will definitely reduce NASH. Interesting study from 2020 hepatology where they showed that, it is a US study, that in compensated cirrhosis, you give vitamin E 800 milligrams per day, it will improve transplant-free survival 78 versus 49 and reduce hepatic decompensation, only 37 decompensation versus 62. So it seems to work even in compensated cirrhosis, so it's something you can give. Saraglitazone is an Indian drug, kind of fast track approval because of very limited data for approval, but sometimes it happens. So it showed a reduction in NASH. It's 34% reduction in NASH score versus 17%. This was statistically significant. So this was the single biggest change. Reduction in the NASH inflammation, but fibrosis was not reported, and my understanding was there was not much change in fibrosis over a 52-week period. So in US there was not approved drug unless fibrosis reduces. But here just with NASH reduction they got the approval. It definitely improves ALT, AST, which we see in clinical practice. It reduces hepatic steatosis also. And it also improves the dyslipidemia. So it is useful in patients with dyslipidemia, diabetes, who also have liver fat. Whether it is the magic drug for NASH, we don't know. They are doing phase 3 studies in the US, so probably in 2 years' time we'll know. Again, an interesting study just published 1 month back. This was a study from Shimla and Srinagar. Very nice study published in our international journal, where they combined saraglitazone and vitamin E, but they did not do biopsy. They just looked at this column. They just used fibroscan to assess the patient. Significant reduction in liver stiffness, which means fibrosis, in the combination drug. They used vitamin E, saraglitazone, and combination, 3 arms. So in the combination arm, there was a reduction in liver stiffness. There was a reduction in ALT in saraglitazone and combination. There was a significant reduction in glycemic parameters in combination with saraglitazone, and significant reduction in lipidemic parameters in combination with saraglitazone. So they came to the conclusion that combining vitamin E and saraglitazone may be a little more beneficial, especially if there is fibrosis, F2 or F3 or even F4. So that's another option for us. Obeticholic acid was given up because the fibrosis, the fibrosis improvement was good, but NASH resolution wasn't so good. There was some concern because the lipid parameters increased after obeticholic acid, and tolerance wasn't very good. So the FDA didn't give approval. It wanted more studies or extended studies. But now, since newer better drugs have come, they have moved on from this. But it is available in India for use in PBC. Occasionally, use it for fibrosis if they are not improving with other treatments. So carefully you can give. If they are cirrhotic, we should not use it because it can cause hepatitis. Non-cirrhotics you can use. diabetic drugs, SGLT2, SGLT2 inhibitors, DAPA, NPA, they are useful for state dose reduction, they are useful for some reduction in inflammation, but they won't change fibrosis, so they won't alter the course of the disease. So they will not get approval as a drug for NASH, but if you have a diabetic with fatty liver NASH, either you or whoever is treating diabetes can add this on to the patient regimen. Many hepatologists are now talking about the patient managed diabetes. It's an open debate. Personally, I am against it because diabetes is the same we can manage fatty liver, we shouldn't need a specialist. So everybody can manage everything, but I think diabetes is best managed by diabetics. So there was a talk in the last council that actually there was a session on it that it's time that we start managing diabetes because it's part of fatty liver. It's an interesting concept. But you can add this as a diabetic agent if somebody has fatty liver, which many diabetics already do. What may be more useful for NASH will be semaglutide. The oral semaglutide which we have in India has a 3 to 5% reduction in weight, has a minimal impact on NASH, especially for fibrosis on whatever 1 or 2 studies. This was a Indian paper from 2017 or 19, I think, 2021, where they are now using injection semaglutide, which is the approved form for obesity management. They use a different dose, 0.1, 0.2, 0.4 daily. Current regimen for obesity is 2.4 weekly, so this will come to the same amount. So what they found was good NASH resolution, but no difference in fibrosis. There is a phase 3 study going on by the same authors called the Essence study, which is 2.4 milligram once a week, the same as the obesity drug. It will probably have an impact because they are seeing almost 20% weight loss in these patients. As I mentioned, weight loss will improve fibrosis, it will improve NASH. So through weight loss it may improve, and also it improves the insulin resistance and glucose metabolism. So they may have a secondary impact on NASH. So if the drug is proven to be useful, it will be another drug that we can use for NASH. But we have to wait for the study to show whether we can use it for NASH. Again, if you have a patient with NASH who has also diabetes, you can consider using, especially the obese. So diabetes, obesity, fatty liver, this is drug we can. This is the new kit on the block. This is the first FDA approved treatment for MASLD or NASH. Resmetirom. It's THR beta agonist, thyroid hormone receptor beta. It promotes hepatic fat metabolism, prevents liver injury from lipotoxicity. It was approved in March based on 12-month study. This was and you may notice that I'm only showing 30%.
இப்போது மேடையில் அந்தரஜாமத்தில் பாட்டுக்கு ஆடப்போறார் சீக்கிரம் ஆடுவோம். One is inside the liver. The newer effects are at the type of lipoic acid, but different ones coming. So these are all great. Bariatric surgery, case BMI 35 plus, is the best way to remove fat from the liver. Almost 90% of people lose fat, and almost 50-60% reverse fibrosis. So it shows that weight loss, which is sustained, is the best way to treat this disease. Without that, it's going to be a challenge. But there are some lean patients with this, so they don't qualify for this. So what do we do for them? So again, lots to learn. So I'll end with that. Thank you.
Thank you, Dr. Ruben, for the excellent talk. First time in my life, I did not interrupt because the talk was very interesting. At least that one person who keeps to the time. Thank you very much. Can I have one or two
It's so
questions?
big for me too.
I will finish up in 20 minutes, I think. I think bottom line is education coming with fatty liver. Now they're all people are aware of this.
Yeah.
To me, I think most of them usually die of cardiovascular or stroke or one of those conditions rather than of a liver disease. It's a very small percentage. So sometimes Dr. Acharya and I may all keep thinking, oh, why are we talking so much about a problem? It's more of a problem of the medical fraternity rather than as a rheumatologist. So I think you highlighted all that, and I think that F3, F4 fibrosis, I think that's the time when we should take off. Because they behave like cirrhosis and high risk also.
You should explain them for cancer.
Yes, exactly. Yeah. Dr. Shankar, a very brief comment, and we have to conclude this session.
Quite enlightening and comprehensive ideas. I just want to know how many people you have cured by giving advice on diet. It is an uphill task.
1 to 2%. Sorry, no.
Now you said about weight calorie deficit 500 to 1000. Is it per day he has to reduce that much or that is the allowed?
No, sir. There is a recommended daily diet based on your weight. So average 70 kg person can take 2,400 calories to maintain the same weight. So if you want to improve fatty liver, NASH, and you're already overweight, then 2,400 minus 500 or 1,000. So 1,500 to 1,800 per day. So from your allowed daily calorie minus 500 to 1,000.
How long it is successful? Sustained?
I thought so, 1 to 2% good.
It's up to the person, individual person.
It's very tough side, I believe, because food is, for us, food is an emotion, it's more than nutrition. So very hard to change that.
Thank you very much. I think thank you very much.
It's time to write a decision. I once again thank the speaker and the chairperson for illuminating us and clarifying knowledge.
We have two announcements. We have the quiz preliminary round on the first
few more felicitations. I would like to invite Kalasam sir onto the dais to felicitate Dr. Mohammad Rafi sir, Professor and HOD of Medicine, Tirunelveli Medical College. Dr. Rajesh sir, Professor of Medicine, Tirunelveli Medical College. Inviting Dr. Jasleen sir, Medical Superintendent, University College.
Radhaswam Aradhyam Karigara Viranchadi Viravi Pranantum Stotum Adamagda Punya Prabhavati Janani Janani Jagani Agani Janani Janani Jagani Agani Jagakarani Paripurani Jagakarani Paripurani Janani Janani Jagani Agani Jagakarani Paripurani Janani Janani Jagani Agani ஒரு மாமழும் சிறு கூப்பிலையும் சடைவாக்குடலும் பிழைவாதனமும் கொண்ட நாயகனின் குடித்தேகத்திலே நின்ற நாயகியே இடபாகத்திலே நின்ற நாயகியே இடபாகத்திலே ஜெகமோகினி சிம்மவாகினி ஜெகமோகினி சிம்மவாகினி ஜெகமோகினி சிம்மவாகினி ஜனனி ஜனனி ஜகனி அகனி ஜகத்காரணி பரிபூரணி ஜகத்காரணி பரிபூரணி ஜனனி ஜனனி ஜகனி பாவனி கரி 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 தரி பாவனி கரி 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 தரி விரி கமத நிசா 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 சசா நிசா கரி நிமி கரி கமதா சசா நிசா கரி கரி மமா மத கத மத சனி கமரி காத்தில் மங்கீதமே என் கண்ணனை அறிவாயா அவன் வாய் உடலில் அழகாக அமுதம் பொழியும் இசையாக வளர்ந்தாய் நடந்தாய் அலை போல் நீதந்து காற்றின் கீதமே என் கண்ணனை அறிவாயா என் பாடல் செவி கேட்கும் விருந்தாகலாம் என் பாடல் நோய் தீர்க்கும் மருந்தாகலாம் என் மேன்மையிலே வாழும் அருளாகலாம் என் மேன்மையிலே வாழும் அருளாகலாம் எரியாத தீபத்தின் ஒளி வேண்டினே எரியாத தீபத்தின் ஒளி வேண்டினே ஏழா கடலும் வானும் நிலவும் என்னுடன் விளையாடும் இசை என்னிடம் உருவாகும் இசை என்னிடம் உருவாகும். நன்றி வணக்கம்.
Sir, thank you so much, sir. That was a really melodious performance.
குருபியர்மகா அடுத்ததாக எங்களுடைய நர்த்தன குழுவுடைய நாட்டியம் நிகழ்ச்சியானது இப்பொழுது நடைபெற இருக்கின்றது. அதில் முதலாவதாக சிவசக்தி நடனம், அன்னையும் என் அப்பன் ஆடவன் கைலாயத்தில் எவ்வளவு அற்புதமாக தாண்டவமாடுகின்றார்கள் என்பதை இப்பொழுது ஆட வருகிறார்கள். With a great applause, we welcome Satana. மீண்டும் ஒரு பலத்த கைத்தட்டல். ஏன்னா அற்புதமாக நமக்கெல்லாம் அம்மையப்பனுடைய ஒரு நடனத்தை ஆடியிருக்காங்க. சிவமில்லையே சக்தி இல்லை, சக்தி இல்லையே சிவமில்லை. அடுத்ததாக அரியுடைய ஸ்வரூபத்தை ஆடவராக கிருஷ்ணராகவும் ராதையாகவும் ஒரு அற்புதமான பாடலை முகுந்தா முகுந்தா என்ற செமி கிளாசிக்கல் நடனத்தை ஆட வருகிறார்கள் நர்த்தனர் குழுவினர்கள்.
I request Ramanujam sir on the dais.
A short introduction to Professor Dr. Ramanujan. So, Professor of Psychiatry, is also alumni of Tirunelveli Medical College. His expertise is only not in the field of medicine, but also in Carnatic music. He has written so many books describing the various ragas of Carnatic music, and also his fascinating work is done. Ilayaraja's maestros, various raga of Ilayaraja maestro, and is exponent in describing every raga, usage of various raga in a particular song. That way he has put up many articles in the media as well as he has written so many books, and it will be available in the regular shops also. And we have been very happy to invite him as not only as a faculty in this conference, but also is about to give a talk tomorrow the Ragas of the Cat. Today he is going to give his performance with his flute. He is not only a musician, but also he can play many musical instruments. We welcome Dr. Ramanujan on the stage.
So, standing in first of all, I thank Shafiq and Dr. Kandasamy sir for giving me this opportunity. I am going to play a song, Kanni Kalemani. M. Chandra will be my mic. Standing.
also from Tirunelveli.
தேங்க்யூ. அடுத்ததாக ஒரு கிராமிய நடனத்தை ஆட வருகிறார் தேவா அவர்கள். தேவா குணா.
sir, Dr. Edil is here to serenade us with a beautiful song.
காதலின் கேள்விக்கு கண்களின் பதில்
Good.
பணிவிடும் வரவரும் உன் பார்வையும் ஒருவரும் I think we need to, because I'm not tuned to this. Sorry. I'm sick from my phone because I want the scroll movement so then I can know how back to start. வேலையை படிக்கணும். ஓகே அந்த மாதிரி கொடுத்துருங்க அப்படி உங்களுக்கு Yeah, stand here and sing. Sorry, please. பனிவிழும் பலவரம் உன் பார்வையொருவரம் பனிவிழும் பலவரம் உன் பார்வையொருவரம் இனிவரும் முனிவரும் தடுமாறும் கரிமரம்
Excuse me, ஒரு photo மட்டும் எடுத்துருங்க. Finish. Hey,